Indonesia, Dr. Nia Reviani M.APS, Consultant at ECRI Asia Pacific, Hasniza BSc, and our Head of Center of Excellence for Patient Safety and Quality, Yanti, SKM, M.Si, and MH.KES. We would like to extend a special welcome for our invited guests, Rumah Sakit Islam Surabaya Yanti, Dinas Kesehatan Kota Surabaya, RSUD Dr. Sutomo, Fakultas Kedokteran UNER, PPNI Jawa Timur, RSUD Sidoarjo, Rumah Sakit Islam Surabaya Jugosari, Pusat Kajian Hukum Kesehatan, Sekretaris Jenderal PPDI, Asosiasi Fasilitas Kesehatan untuk Fasilitas Kesehatan Tingkat Pertama Jawa Timur, Kelompok Komunitas Pasien, dan kelompok pasien dengan disabilitas. We would like to give thanks to God for His blessings so that we can gather together here today, offline and online, at the first International Symposium on Patient Safety and Quality. The International Symposium on Patient Safety and Quality is a global forum that brings together experts, healthcare professionals, practitioners, and researchers worldwide to discuss issues related to patient safety and quality. This event aims to promote the basic principles in healthcare, share the latest knowledge, and identify the latest innovations to improve the quality of patient care. The symposium also provides an opportunity for networking and collaboration to achieve common goals in advancing patient safety worldwide. Before today's seminar event is officially started, please allow me to present the agenda for today. The first, we will start with national anthem. There will be also traditional dance, opening remarks, first session of panel discussion, Q&A session, coffee break, second session of panel discussion, and certificate presentation. Without further ado, we will start the event by singing the Indonesia's national anthem, Indonesia Raya. Kepada para hadirin dipersilakan untuk berdiri. Next, we will together enjoy the beautiful performance of traditional dance of Indonesia, Saman. Saman is one of the most popular dances in Indonesia. Its origin is from the Gayo ethnic group from Aceh and is normally performed to celebrate important occasions. The dance is characterized by its fast-paced rhythm and common harmony between dancers. To the Saman team, please come forward to the stage.
Hai jun majun di kura-kura gunung, di teman-teman udah doanya, urau di potong mama di sate, malaikat kejedot tema. Hai jun majun di kura-kura gunung, di teman-teman udah doanya, urau di potong mama di sate, malaikat kejedot tema. Hai jun majun di kura-kura gunung, di teman-teman udah doanya, urau di potong mama di sate, malaikat kejedot tema. Hey, dekat menenang, dekat menenang, coba kemana? Si cuma kira si ulai karela anak, dekat menenang, coba kemana? Si cuma kira si ulai karela anak, dekat menenang, coba kemana? Si cuma kira si ulai karela anak, dekat menenang, coba kemana? Hai Karunano dalam gelanggang, tua gelanggang si Raja Wali. Karunano dalam gelanggang, tua gelanggang si Raja Wali. Lalu bergorahaya malah ihalan, lalu bergorahaya malah oheli, lalu bergorahaya malah ihalan, lalu bergorahaya malah oheli, lalu bergorahaya malah ihalan, lalu bergorahaya malah oheli. Aro pulau Pinang tidak ada gelombang tujuh, lampau pertama yang di dalam minyak mabuk. Aro pulau Pinang tidak ada gelombang tujuh, lampau pertama yang di dalam minyak mabuk. Irilah operasi doi tarik buka, hai ulah gidara agak berkaca, hai putih kuleng di dalam darah, masa tak ingat pulang datang. Aro pulau Pinang kita ada gelombang tujuh, lampau pertamanya di dalam minyak mabuk. Aro pulau Pinang kita ada gelombang tujuh, lampau pertamanya di dalam. Hai putih teh, koma hai putih teh, hai putih maba yang koma boha tema, udah dunia puja Tuhan, udah di mama bersaya lupa. Hai putih teh, koma hai putih teh, hai putih maba yang koma boha tema.
Next will be the opening remarks by Directorate of Healthcare Quality, Indonesian Ministry of Health, Ibu Dr. Yanti Herman, M.Si. Kepada Ibu Dr. Yanti Herman, M.Si, waktu dan layar saya persilakan.
Ya, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Excellence for Patient Safety and Quality, University of Airlangga, para keynote speakers, para sivitas akademia, dan Bapak Ibu hadirin semua yang berbahagia. Alhamdulillah kita sudah bisa mengikuti puji syukur, bisa mengikuti acara ini dalam keadaan sehat walafiat. Bapak Ibu semua, mutu dan keselamatan pasien merupakan prioritas utama dalam pelayanan kesehatan. Fasilitas pelayanan kesehatan, tenaga medis, dan tenaga kesehatan harus mengupayakan pemberian pelayanan dengan standar maksimal dalam diagnosis, perawatan, dan tindakan medis untuk melindungi kesehatan dan keselamatan pasien. Selain itu, sistem pelaporan dan pembelajaran dari insiden atau kejadian keselamatan pasien yang terjadi di fasilitas pelayanan kesehatan juga penting untuk terus meningkatkan mutu layanan kesehatan. Di samping itu, peran pemerintah pusat dan peran pemerintah daerah dalam mewujudkan penyelenggaraan pelayanan kesehatan yang aman, bermutu, merata, dan non-diskriminatif di PUI-PT juga amat dibutuhkan. Bapak Ibu semua, Undang-Undang 17 tahun 2023 tentang kesehatan secara eksplisit telah menetapkan bahwa keselamatan pasien menjadi kegiatan yang wajib dilakukan oleh setiap fasilitas pelayanan kesehatan sebagai bagian dari peningkatan mutu pelayanan secara internal. Untuk selanjutnya, di dalam rancangan peraturan pemerintah turunan ataupun amanat dari Undang-Undang Kesehatan tersebut akan dituangkan bahwa pemerintah pusat akan menyusun strategi nasional keselamatan pasien
Such a powerful speech. Thank you, Ibu Santi. Next is the opening speech by the Deputy Chancellor for Research, Innovation, and Community Development Airlangga, Universitas Airlangga, Profesor Dr. Nyoman Puspaningsih, M.Si. Kepada Prof. Nyoman, waktu dan tempat saya persilakan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera dan salam sehat bagi kita semua. Good morning and greeting to all of us from Universitas Airlangga. So the Honorable Dr. Yanti Herman, SH M.HKES, Director of Healthcare Quality, Ministry of Health Indonesia, Dr. Nia Reviani M.APS, Assistant Deputy of Coordinating Ministry for Human Development and Cultural Affairs Indonesia, Professor Kan, our guest from Singapore, from the Singapore Duke National University of Singapore, Institute for Patient Safety and Quality, Singapore. Ms. Hasniza Zahidi, BSc from Emergency Care Research Institute or ECRI, Asia Pacific, Ibu Dr. Yanti, also the head of the University Center of Excellence atau PUI-PT for Patient Safety and Quality, Universitas Airlangga. So all honorable distinguished, the speaker, moderator, and also participant of the workshop who joined by the hybrid, online and offline in this event. So ladies and gentlemen, on behalf of the Rector of Universitas Airlangga, Professor Dr. Muhammad Nasi, I'm honored to extend my warmest welcome to all of you on behalf of the Universitas Airlangga. As we gather forth to the first International Symposium on Patient Safety and Quality, proudly presented by the University Center of Excellence or PUI-PT Center of Excellence for Patient Safety and Quality. Distinguished participants, Universitas Airlangga always places great emphasis on research and community services as central pillar of our mission. As higher education institution, our commitment to advancing knowledge and providing valuable contribution to society drive us to explore and address complex challenges such as the subject of the patient safety. This symposium is a result of collaboration not only with our distinguished speaker but also in cooperation with patient family, patient advocate, healthcare provider, health worker, community and experts, all driven by a shared passion for improving patient safety and quality in Indonesia. Distinguished participants, patient engagement is a cornerstone of effective healthcare delivery and also plays a crucial role in improving overall healthcare outcomes. Patient engagement in patient safety is a collaborative approach that leverages the expertise of both healthcare providers and patients to create a safer, more patient-centered healthcare system. This partnership is fundamental to achieving the shared goal of providing high quality, safe, and effective healthcare for all. Therefore, the purpose of this symposium is to enhance communication, coordination, and collaboration among various sectors, ultimately fostering integration and alignment of policies and programs, particularly in patient safety management. The expected outcome of this symposium is the development of a roadmap for patient safety management, complemented by contribution from the respective institution overseeing this program and policies. Distinguished participants, ladies and gentlemen, allow me to extend my heartfelt gratitude to the Sing Health Duke National University of Singapore and US Institute for Patient Safety and Quality, Singapore, Emergency Care Research Institute or ECRI Asia Pacific, Ministry of Health of Indonesia, Coordinating Ministry for Human Development and Cultural Affairs Indonesia, also organizing committees, speakers, moderator, and all participants who join this program by hybrid. You are all dedicated your time and energy to make this symposium is a reality. Your involvement is crucial in making this symposium success, and also your contribution will undoubtedly leave a lasting effect on the future of patient safety management. Let us move forward together, harnessing the power of collaboration to address our time's challenges and nurture innovation and also the growth. May the shared knowledge, connection, and insight gained during this event propel us toward a brighter and more sustainable tomorrow. Thank you for being a part of this pivotal journey, and I eagerly anticipate the groundbreaking discussion and also solution that we will forge together over this event. So I wish you all a fruitful and inspiring symposium. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Duke and US Institute for Patient Safety and Quality has been active in integrating cluster-wide efforts in patient safety and quality within the Singapore Duke and US Academic Medical Center. IPSQ's goal is to eliminate preventable errors and harm and improve patient outcomes by building and cultivating a strong patient safety culture. IPSQ collaborates and connects with external partners such as WHO Patient Safety, International Council of Nurses, and countries such as Maldives in advocating for education and professional development in patient safety and quality to improve patient outcomes and deliver safe care, as well as sharing of best practices. So for the MOU contract signing, are we ready for
Good morning, selamat pagi. Dr. Yanti Herman, Director of Healthcare Quality in the Ministry of Health, Indonesia. Deputy Chancellor Nyoman Puspaningsih, Vice Chancellor for the Research and Innovation and Development in Airlangga University. Dr. M.Si, Head of the Center of Excellence for Patient Safety and Quality in Airlangga. Distinguished speakers, ladies and gentlemen, and friends of patient safety. Thank you very much for the kind invitation to this first International Symposium on Patient Safety and Quality at the Center of Excellence for Patient Safety and Quality, University Airlangga. It is nice to be here in this beautiful city of Surabaya, the second largest city in Indonesia and the cities of Europe. University Airlangga has 6 campuses and is home to 13 faculties and 2 schools, and has 187 study programs which cover wide-ranging fields from life science, health science, technological science, and social science. Its vision is to become an independent, innovative, and leading university, both at the national and international level, as well as to be the pioneer of development in science, technology, and humanities based on religious morality. The Center of Excellence for Patient Safety and Quality, Airlangga University, is Indonesia's first Center of Excellence for Patient Safety with support from the Ministry of Research, Technology and Higher Education in Indonesia. Singapore Health, or SingHealth in short, is united by the common purpose to put patients at the heart of all we do. SingHealth institutions span from primary to acute care, and the fundamental principle is to place patients at the heart of all initiatives. The aim is to ensure that patients remain well supported as they journey from one care setting to another. The SingHealth NUS Academic Medical Center, with the network of acute hospitals, national specialty centers, community hospitals, and polyclinics, covering over 40 clinical specialties, draws on the collective strengths of SingHealth as well as the NUS Medical School to drive the transformation of healthcare and to provide affordable, accessible, and quality healthcare. As an academic medical center, the convergence of clinical care, education, and research enables SingHealth to pursue innovations to deliver better and more accessible care to its patients. Beyond the hospital wall, SingHealth has taken stride to build a strong care network with partners to enable the Singapore population to receive the right care close to their homes. The SingHealth NUS Institute for Patient Safety and Quality aims to develop both healthcare professionals and patients to become advocates for and to be leaders in patient safety and quality improvement to enhance the capacity in improving patient care. As part of the collaboration, we are happy to sign this MOU today, 20th of November 2023, and to work together to promote patient safety and healthcare quality activities for our countries and for the region. I look forward to this successful symposium and fruitful collaboration between the Center of Excellence for Patient Safety and Quality, University Airlangga, and our SingHealth NUS Institute for Patient Safety and Quality. Thank you very much. Terima kasih. Thank you.
So, ladies and gentlemen, we will then move on to the first session of panel discussion. which will be moderated by Ibu Rista. Ibu Rista Fauzin M.APS is a lecturer in the Faculty of Nursing Universitas Airlangga. She obtained her B.MSc and Master of Nursing from Universitas Airlangga. Graduated her PhD study in Faculty of Medicine, University of Malaya. She has been active in the area of gerontology. To the stage.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. It's very honorable for me to become moderator for this session today. Before we start our session, I will invite our very distinguished speaker. For the first speaker, I will invite Dr. Nia Reviani M.APS as Assistant Deputy for Health Service of Coordinating Ministry for Human Development and Cultural Affairs of the Republic of Indonesia. Please welcome Dr. Nia. Give applause, please. Thank you. And for the second speaker, our distinguished guest from the Sing Health News Institute for Patient Safety and Quality under Singapore Health Services or Sing Health. I will very honored to invite Professor Tan Ko Hian. Welcome, Prof. Before we start, I will read the short CV from our speaker. For the first is Dr. Nia Reviani M.APS. She is a Bachelor of Medicine and currently working as a lecturer at the Department of Public Health at Christian University of Indonesia, and as a government employee, Assistant Deputy of Health Service Improvement Coordinating Ministry of Health and Cultural Affairs. She began her career as a government employee for the National Population and Family Planning of Indonesia or BKKBN since 2006. After completion her medical doctor from the Christian University of Indonesia, Jakarta, she completed her master program in the field of population studies at Flinders University, South Australia. She has been serving as a lecturer for 5 years and as a government employee in a different various positions for 16 years. She has experience in strategic forward planning, operating within the tight financial discipline, methodical administration to deadlines, and the application of modern leadership methods through staff motivation and involvement in both decision making and target setting, clarity in communication, and easy personal interrelation. Okay, now for the next. Dr. Nia, you will have 30 minutes to present for us, and please welcome to the stage.
Actually, I don't like this one. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. It's such an honor for me to be here for the first International Symposium on Patient Safety and Quality, Professor Tan. Nice to meet you, and also for the field speakers and audience who's joining online and online. Like mentioned before by the moderator, thank you for announcing me that my name is Dr. Nia. I'm working as an Assistant Deputy for Health Improvement under the Coordinating Ministry of Human Resources and Culture. If you notice, Kemenko PMK, well known as MH.KES before. So we're shifting into the Kemenko. Thank you. We're shifting from the Kemenko KES into the Kemenko PMK. So I will start my presentations, but this is more likely about policies in Indonesia. If we talk about health, maybe some of you relate to the Ministry of Health. But for your information, there is like a Ministry of Coordinations. Can I put this slide on? Yes. Sorry. Okay. When we talk about Kemenko PMK, you all see the logo. This is the coordinator minister. So under the presidents, we have line of ministry that collaborating, which coordinating, not only coordinating, synchronizing, and also controlling all the programs, all the policy makers. So as you can see, that Ministry of Religion, Ministry of Health, and then also some of the institutions like National Population and Family Planning Board. But you have to know that under the Kemenko PMK, they have to report it, institutions and also line ministries to the MENCO. We call it MENCO, Minister of Coordinator. So, and usually every month we have like a meeting, we have evaluation meeting in terms of the health. For instance, that we advocate Ministry of Health, BPJS in relation to the national scheme of the health insurance of the people of Indonesia. And this is the life cycle. Maybe this is a very small pictures here, but you can see this is all the target when we talk about from the beginning of life, day 1, 0 life, until the elderly. This is all the problem and also having like a target. And usually that Kemenko PMK making like distributions work for the line ministry and institutions when we call it prenatal, and then what about the initiation menyusui first life of the baby into elderly system. So when we talk about patient safety and quality, it's not only mentioning about one ministry's work. This is also line ministries and also institutions. I will show you about the coordinations of the Kemenko PMK. This is the functions of the Coordinating Ministry of Human Development and Culture. This is not a small task because we're not only controlling, we're not only synchronized, but we're also making all the policies gain and then reporting and then also delivered into the same position into the society. We always selling some of the items, some of the policy. It's not only policies could be managed by the government, but also by the local people into the district people. And as you can see that there are two major projects. You know that under nutrition baby stunting program. Maybe Professor Chancellor heard about stunting. Stunting is under nutrition baby. We make huge programs about it. It's not only the level of the government, but also into the grassroots. We advocate mother, we advocate people to commit to make healthy babies, to commit into a proper health, and also this transformation of health. Ministry of Health making a health scheme of transformations. Maybe in my last slide, I will show you there are 6 pillars that are committed into the government from the national level and then also from the services in the periphery, we call it in the national, into the low level, into the Puskesmas, and also how do we manage the human resources, including the doctor, midwife, pharmacists, and many others. And talk about policies. This is a very, important, because some of it think that policy is only from the top into the bottom positions. but none. Some of the policy came up from the bottom. For instance, that few days ago that I just back from Kepulauan Riau, Tanjung Pinang, one of the focusing of the coordinating ministry is the mental health people. As you can see that mental health is not an easy task to do because it's a special case. Hospital, rumah sakit jiwa. Can I speak in bahasa? Yeah, okay. Actually, I want to speak in English, but some of you are bahasa. So, Professor Tan, let me speak maybe combined. So, back to Kepulauan Riau. This is an example yang buat saya benar-benar terkejut bahwa kita punya 38 provinsi sekarang, 38 provinces. But 8 of the provinces, they don't have hospital for the mental disorder. Can you imagine that if it's like people sick, so having like mental disorder, and then the community didn't support it, and then what about the family? So it related into the patient safety, family, and then patients should be gathered, yes, for sure. If it's like one of your family sick, kenapa saya pakai bahasa Inggris lagi ya? Jadi, I don't know, it's like switch modes. Okay. Doesn't mean that to be like some of the persons called like a switching mechanism, but I think, and then for example that when a family having like a member who's having like mental disorder, this is like a very task, very hard to do because it's not like you have a cough or you have fever, you go to doctor will give prescriptions, medicines, done, you'll be happy again. But for the mental health disorder, this is like a series of treatment that should be done. This is like also cancer. We know that when we deal with cancer, like family with the cancers, you have to do that series of chemotherapy. And this chemo cannot be managed only for one reason. There is like a series, and maybe like 20 series of chemo. And the policy should be attached to the not only for the services, but also for the financings. And when we talk about policy, this is a set of ideas, plans. What will you do? What is government's task? And talk about health. It's not that easy. Okay, now we know Sistem Kesehatan Nasional, transformation of the health system, transformations of the health, and making the community aware of the health of the people. But it's not an easy task for the government. As I can announce that the financing for health is over budget. BPJS Kesehatan is always like making reporting, Dr. Nia, I think we have to make, proper policy because rich people, poor people, we have to cover all. This is an insurance not only for rich people, Professor Tan. This is insurance like in Australia when I have my master. Like a Medicare, it's covered for all people, including me. I'm a student, I'm only like temporary person there, but they cover my health. And public involvement policy, when we talk about patient and family, like my previous example, this is an easy task to say, but not an easy task to do. Public and then also family. If it's like you have well-educated family, you will commit it. But what about people in the villages? What about if you don't have like people or family who's not having well-educated? It's gonna be a problem. For example, stunting baby, undernutrition baby. If Dr. Nia, for sure, and I don't want to have like undernutrition baby, but for people, they're poor, they live in the villages, they cannot access to the health services properly, it's going to be a big question mark, not only for the government, but for people and also academicians that should we do something else and should we do what is the strategy to make the government's policy into the level, into the grassroots policy could be managed and then attached to the people. Yes, the benefit, when we talk about policies, yes, of course, society, the people, and then the health. Benefit, patient-centered care. Patient will be caring much. We know that if you have lots of money, you can go to the private hospital. But what about if you're poor? If you don't have insurance like BPJS, you don't have covered for the payment for your health insurance, it's going to be a problem. And nowadays, thankfully, the government committed 95% of Indonesian people are already covered by the BPJS. But some of it, they always mention that, Dr. Nia, it's hard to do, it's hard to claim, it's hard to reach because the access. We are happy, we are living in the city. What about people in the villages, in the island, in the mountain, in the conflict area like Papua? Last week I went to Papua, Professor Tan, from Jakarta to Jayapura, Jayapura, Wamena, Dekai. I went to Dekai. Dekai is a very isolated island. I went there, I had to use only public transportation is airplane, a small airplane. I went with pig, chicken, yes, with fish, because it's only like 9 people on it. But in my opinion that there is like society need and advocate, need more quality of health. They only have one hospital, I think government hospital, only 4 doctors to manage that island. Can you imagine? It's only by airplane, cannot be using boat because it's a mountain area. What about the island? I went to Kepri, Tanjung Pinang. From Singapore is close, yeah, because we can move forward from the Batam to Singapore. Tanjung Pinang to Singapore as well, we can, but they don't have hospital for mental health disorder. They're just shifting one national, one government hospital into a very specific mental health hospital. And I was happy to try because this is like a commitment from the national and also the local government. They know that the era of pandemic, 3 years that we've been through pandemic, this is not an easy situation. Why? Maybe some of you, maybe you can see the next person who sit next to you at the office, at this table, maybe he has disorder. We don't know. Maybe he have like sleeping disorder. Maybe he have like anxiety disorder. I can mention some of the artists now, they have anxiety disorder because of the situation that they cannot control. And what do we do if it's happened to their society? If it's like we are closing to the access to health services, it's not a big problem. But what if the people who's living in the remote area, in the villages, who's like far away from the access for health service, it's going to be a big problem. Nice. What next slide? Can I see this slide? Because I see my face. Screen? Yes. Okay. Okay, from here. Health and well-being for all. Yeah, this is a concept. People, yes. Who will be the benefit of this? Yes, for sure, people in Indonesia. And thankfully that continuity, accessibility, and also the system we are maintaining to develop each by each, year by year. We progress some of the activities, some of the access which is close to the people. It's not an easy, yes, because one thing for sure, the quality. If it's your sake, you have to be easy to access the health services. But if you have like private insurance, of course, you can go to the Singapore, you can go to other countries for using the services. But what if we are not having that opportunity? We don't have the benefits that I mentioned before. This is efficiency and talk to the scheme of the financing of health is not an easy task because covering 270 million of the people of Indonesia is not only 10 million of the Jakarta people, but all over people in Indonesia. Not saying rich people, not saying poor people, but all of the people of Indonesia. Easy way to do? No. I can say it when we see the framework of patient and family engagement. Honestly, when you invite me to this symposium, I'm just thinking this is related to my work. Because as Assistant Deputy for Health Improvement, Health Services Improvement, this is like a framework. This is a framework of patient and family engagement. We cannot come only to the healthcare providers. We also have to manage family, engage the family. Because if it's like you're sick, you cannot only count on the health providers. You cannot count on the doctors or the midwife. What about if you, after doing the treatment, for example, the chemo, you will go home easily. After you go home, you will be attached by the family. Then this is the concept that we have to fulfill. Because when one person in your family is sick, for sure that it will be affecting all of your family members. I can say, no one will be happy if your family members, for instance, your husband is sick. How can you focus on your work? Me. Last year that I have to do some spine surgery, Professor Tan, it cost reducing my quality of life because I live with pain. But I noticed one thing for sure, that when I in pain, I'm asking for help from my husband, from my sons, from my assistant, from my staff at the office. And then I realized that, okay, I have to do things. I have to do something else that could manage this inequality, that inequality life of me. I change it. So I take the surgery and it's changed my life. Before it's so painful. In the scale of 1 until 10, it's 9. So can you imagine that I have to fulfill all the family members, all the staff members to help me if I'm in pain, if I have that pain. Okay, I will show you one of the concept. We call it data satu sehat. Satu sehat data. This is like a dream come true. We have like an apps. We have like a big data, which is collaborate, which is including of your health status. It's not only like your name, but also your illness. What have you been done? Like me, I have to do 2 operations for my surgery or for my delivery baby. I have to do spine surgery. So it's gonna be like a report from this data, and then you can access it. No, people cannot because this is a private data. So data satu sehat. This is a data that's only announced a few months ago. And it's under a collaboration into Life Ministries, and also we know when the pandemic occurred, we have to peduli lindungi. We have to make the certificate of the vaccinations. We put it. If we want to travel, we have to show it. And then this is what it's called. This is the penyempurnaan dari konsep peduli lindungi into one of data satu sehat. And there are many issues when we talk about data. It's not easy to gather all the information. Some of you think that, wow, what about the privacy issues? This is the data that only can be accessed by yourself. And also that gathering all the information. Sometimes we are like lazy to put information that relate to our health. But I'm asking for you to see there is like a primary and secondary care need the data of you, which is then if you have something in the future, we know the report and the record, so we know what to do in the future, and hopefully this collaborations, this data can be one of the example that Indonesia is moved forward into a data system. So, example for the health policy, we know I mentioned lots of the financing of the health, and this is like implementations of universal health coverage in the future that we will cover all people of Indonesia. But we also have like some of applications which is related to the stunting, underweight nutrition. This is the example for the disease of prevention of non-communicable disease. We know stroke, hypertension, diabetes now is very silent killer of people in Indonesia. I lost my dad because of hypertension too. So we have to know that it's not easy. This application is only like applications if we don't have to support, if we don't support it. if you don't commit it to show it to the people, if you don't use it. Because like BPJS Kesehatan, Professor Aligo from the chair, he always mentions that we almost gain 95% of the people of Indonesia into the scheme of the financing. But what about the rest? How we make 100% of it? So this is like strategies that we have to involve and collaboration. For sure, this is not an easy way to do because it's not only like the government at the central level, but also in the government in the district level. And transformation of health. I just show you the area. Yes, this is the area of reform in national health scheme. Transformation is not easy. Because when we can see about what is the strengthening of the health, access to the health, what is the main strategy? We provide all the cadre, we provide all the doctors, we provide midwives into the health. If it's like we put doctors, for example, doctors after graduating from medical doctor, they have to do the internship, Professor Tan. They have to go to the villages. They have to be there for 1 year, and then if it's like not safe for them, they will go. They will love the villages. And this is like a strategy that I always like making like coordinations. What will you do? If it's like a doctor, we don't have puskesmas tanpa dokter. We have like health centers, but there is no health care providers. So it's useless. And health financing is also like a big problem. Disease control, like I said before, we have lots of applications like of digital health transformations, but some of the people know prevention is better than curing. Prevention and promotion is better. But what about if it's like you've already dealt with it? Hypertension, for sure, that is about track of that. You have to take these medicines. You cannot leave the medicines. You have to do proper control to make sure that this hypertension cannot cause complications. And maybe this is the last slide. This is the 6 pillars of Indonesian health system transformations. Layanan kesehatan rujukan, primer, pembiayaan, health services provider, and then also transformations digital. There are 6 pillars. It's not an easy task to do, but the commitment we already shifting into health system transformation, integrasi layanan primer. We make lots of health centers. We delivered a lot of medical doctors, midwives, nurse into the health centers in the villages. So we make sure the health of the people. So in my conclusion, preventions and promotion is a big thing to do. It's not a simple thing to do. We talk about patient safety and quality, but one thing for sure, we have to start from the beginning. Well, if it's like patient safety, yes, I agree, I approve it. We have to make patient safety and then also making the qualities of the people are high. But starting from the beginning, we have to ensure from the beginning, from the young people, you have to know it's not like life is like a cup of coffee and then done. No. It's full of preventions, it's full of commitment to be healthy, and one thing for sure, if you're already dealing with one of the conditions that need to be do a health care system, you have to make a proper treatment for that. Maybe that's my last presentation. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
you.
Thank you very much for inviting me to give this, to be part of this symposium on patient safety. Can I have the slide, please? Right. So I will be talking about patient engagement, and because I have been the focus of this symposium, and also for the WHO Patient Safety Day, the World Patient Safety Day. And I'll be looking at some of the best practices from Singapore and beyond. So this is my disclosure. I have been involved in patient engagement since the time when I was a quality director in 2004. My scope of this short presentation, half-an-hour presentation, is to look at the culture and mindset about patient partnership. And then I will talk about 4 best practices or good practices from our institution. Then I will look at some aspects of moving forward from there. So, as you know, patient engagement, patient partnership is very important. And in fact, if you look at the quality of care, look over here, you will see that people-centeredness of providing care that responds to the individual preference and needs or values of patients are there. So that's the health care quality. Right? And then if you look at the healthcare qualitative aim, and again here you can see that one of the aims is outstanding patient experiences. Right? That is important. And in the WHO recently, where we had a conference on engaging patients for patient safety, one of the things is that if it's not safe, it's not care for the patient. So it's very important to focus patient engagement in patient safety. And here we have the Global Patient Safety Action Plan. If you go through the strategies, objectives, you look, one of them, number 4, is actually on patient engagement. And we were looking at how we're trying to engage our patient within the institution. I was speaking at the WHO conference. If you look at global patient safety, you can actually divide it. It's very actually simple to remember. The first aspect looks at the mindset and the culture. The second strategy of this focuses on having high reliability care, looking at the system. The third relating to making sure the processes are safe and high quality. The fourth is relates to patient engagement. Of course, number 5 is about staff education and training, and how do we manage our information, and how do we collaborate together. So this is a global patient safety action relating to patient and family engagement. So what we have here are the 5 objectives. Number 1, we must inform and educate our patient very well. Number 2, if there's an incident, we need to have a patient safety incident disclosure to the victims, be as transparent as possible, and also to learn from patient safety experiences. And also, some of them will become patient advocates, and some of staff will be patient safety champions, and we can now co-develop policies, co-produce care for the patient, because the patient is an important stakeholder. Right. So together with the patient, we look at how we can achieve high reliability care and to target zero harm. So zero harm events, zero overuse, zero medication errors, zero complication, zero unaffordable care. Right. It's very important, and just now the previous speaker was saying about the need, to have a commitment. Leadership commitment is extremely important, followed by culture building. And one culture building, one is the patient partnership culture. Right. So what do we need to do in order to move forward? Firstly, leadership actions for patient engagement. We need to change our staff, the mindset that it is important to have patient partnership. And looking at changing the population as well, the patient mindset, working together for better health care. And then, of course, we will need to have capability and capacity building. So, in Singapore, in our institute, we look at this aspect because the common purpose of our of Singtel is actually over here, the common purpose here. Patients at the heart of all we do. So we always focus on that. And our group CEO, Professor Ivan, says, what our patients want, what is it that we want, is what we want, right? What the patient wants is actually what we want. Right? So there's some synergy, right? So we have a lot of training programs. I just like to show over the video that we have got 20 training, 20 interprofessional continuing education program, and a lot of them relates to building the culture and also to be able to even advise patients how they can communicate better with the doctors and how the doctors communicate better with the patients. Right? We have a master's degree and graduate diploma degree that also focus a lot on it, and one of the things that we teach among our students is to be able to master the ability to do open disclosure. It's very important to be able to facilitate open disclosure as well. So basically, in the sense that we are supposed to be focused on the disease, now we need to focus on the person who has the disease, and that's what we call patient-centered care or person-centered care. And it's very important to know that the determinants of care is not just about the health care you're providing, it's also the social, the environment, right? Very important whether they live in the mountains, the hillside, it's the environment, and very important to ensure that within their environment, the community, they have good community support as well. And this has been shown here that mortality rate actually depends more on the social determinants rather than the health care that you provide determinants. Shown over here, proportional distribution of premature death in terms of environmental, behavioral, and social factors are much more than the health care. Right? So in Singapore, we actually model a care called the Esther Network, which we actually learned, which is a person-centered care innovation from Sweden, where it is actually where we focus on addressing the patient's needs through the network, through coach training, and through the resources that we combine within the community itself. This is the Esther Network, and we have it since 2016, because the word Esther actually symbolizes a patient whose health and social care requires close coordination across different care settings. And we aim to do that for that patient, not just to provide the care, but when you go to community, how can the care be sustained and supported in the community, right? So this is one of our yearbook, the Esther Care Yearbook, where we feature examples of how we support this concept. There's leadership support and encouragement. So this is an example of a 72-year-old lady with multiple medical conditions and multiple ambitions. And there is emotional and social needs as well, besides the medical and health needs, and how we coordinate all the care to provide for their needs as well. And in fact, there's a word called social prescribing, right? You heard of medication prescribing and social prescribing. Social prescribing is a holistic approach that connects people to activities, groups, and services in their community to meet the practical, social, and emotional needs that affect their health and their well-being. So that's the Esther network itself. So in fact, we look at what, for example, a lady with diabetes, with blood vision, and we use all the small little tags, but actually what you need in order to monitor well is to have actually, for us to make it bigger, right, to make it easy for her to actually log the information down. Similarly, there is a patient with multiple medication. I think counted was 32 prescribed medications, and you need someone to help him to sort it out, to be able to ensure that he's able to take the medication that is appropriate and discard those that are inappropriate or those with a lot of interactions, and make sure that it's up to date, the medication. So basically, within this, we also provide community support. We liaise with the community support to ensure that the patient will be given the necessary social and support. There's a saying in Mandarin here in Chinese, it's actually a close neighbor is better than a distant relative. The person that can help you is a close neighbor, not your distant relative, somewhere in another country or so. Right? this is one of the practice. The second practice is that how can we improve the activation levels of the patient? You know, patients come in different types, right? All of you, right? You see patients who are very non-compliant. You know, they require a lot of needs, and I think you need to be able to come to them to see how you can make them compliant, how you can connect them with people. Then there's another group who are the super activated. They are compliant. They know they will participate in your care itself. So how can we harness this group of patients to help us in healthcare, right? And for example, here they can help in detecting and reporting near misses and adverse events while they are in the program. They can participate in programs that educate patients about safety hazards. They can take an active role in patient safety and be involved in driving efforts to improve the culture of safety, right? So here we have different levels. They can be in patient support groups. They can be in person-centered care where they provide feedback and participation in a program program, or they can be in patient-partnered care entities in the West, they call it Patient and Family Advisory Council. In SingHealth, we call it the SingHealth Patient Advocacy Network. So I'm going to tell you about the SingHealth Patient Advocacy Network because we believe that we should go beyond just person-centered care. We want patient partnership care. We want to create this to replace the old paternalistic healthcare system. So, which is why we initiated SPAN, which is the SingHealth Patient Advocacy Network. Here we have the mission and vision and core values, and it started initially in 2017 as just focus groups, and then and now we've grown to almost 100 patients supporting the initiative. They are semi-autonomous in the way that we provide the secretariat, but they decide what to do. They come up with their own mission, vision, core value, and strategic trust. So their vision is empower patient at the heart of quality healthcare. Right? So we want them to be empowered. So they have various focus within themselves. They have various focus areas to be able to drive membership and engagement, education and patient experience, and publicity as well. Right? So through them, we build awareness of patient advocacy. We engage healthcare teams to partner patient and advocates. We actually would ask our healthcare staff to engage SPAN early so that they can get the maximum benefits. We also provide patient population advocacy communication training, and this is by the SPAN manager. There is a patient telling another patient how to communicate with the healthcare staff in the best possible way. And this is very important for that. They do a lot of projects, for example, co-design safety and experience with healthcare teams. This is about the wayfinding activities. They even co-design protective headgear for neurosurgical department. They look at patient bedside tablet and they provide useful information. They come up with develop plain English glossary for healthcare staff to use so that they can better communicate with the patient. And they design and publish the plain English glossary. They look at various aspects. They're actively involved in training for themselves and for the healthcare staff. Right? They build positive relationship and caring for healthcare teams. They curate patient story within that. So see, you can see the magic, and in almost all our activities of patient safety, they are involved. SPAN members are involved. Right? Even they go to the national level, they write an article in our national media to say what? To say, say no to abuse and speak up for them. Speak up for the healthcare workers. Imagine the patients themselves saying to speak up for healthcare workers, do not abuse our healthcare workers. Right? And there's a lot of projects that we have done, and when we counted, it's almost like above 100 over projects they have done together. Right? And there's growing numbers, and because there are a lot of them who are very interested to help out because they have their disease. They get cured, they get remission, and they felt they want to do something for the healthcare system. They want to go beyond their disease that they are suffering from. So, in fact, they presented with me with IHI about how to initiate a patient advocacy network and how can we build a strong advocacy network. So they were actually speaking, they are just speakers at this conference, an MH.KES conference, to do this, and they also publish articles in the journals themselves. So you see, the patient is a very powerful force. If you can harness it at the other end, it will help us a lot. The other important thing which I know is that you must know about patient stories. These patient stories, we are able to curate them well, able to use them. It will be the very good drivers for patient engagement and patient safety, right? Because they will grasp the impact of activity on their actions and decisions on the patient's life. Right? So at the recent WHO conference on celebrating the Patient Safety Day, we M.Si together with WHO Patient Safety Day launched the Global Patient Safety Knowledge Platform, right? GKPS.net. So this is the where we actually collate all the patient safety material, and in particular, what we want are the patient stories. Right? So we have actually over 140 patient stories, and I'm sure that many other stories that will be relevant to your country that you can actually collate itself. And because these are very powerful engagement pieces, right? Because they are drivers of patient engagement and patient safety. They evoke empathy and a sense of purpose. They fuel engagement and advocacy, and they are valuable education tools which will promote transparency, encourage open discussion, and inspiring change at various levels. So, now it has become part and parcel to use patient stories at some of our meetings, right? Sometimes we start a meeting, a board meeting with a patient story to make them understand that it's about healthcare. Healthcare is about the patients, and the patient stories, that it is very important. Maybe history board meeting, medical board meeting, department meeting, town conference, policy makers meeting, media newsletters, and website stuff. So there are many. I would suggest maybe you may want to go to some of these very good stories that is, in fact, they actually change healthcare system because of their stories. A certain institution takes certain steps in certain countries to be able to improve the care. In Singapore, at least in SingHealth, we have a patient, a professor who become a patient. He's a professor of looking at prostate cancer, and he has prostate cancer. Imagine, he goes through himself, he thought that he knew. Who is that? I thought I knew, but he actually didn't know of what the patient goes through. So after having gone through it, he realized, why is it that patients always default care, they are non-compliant, they don't seem to want to do things. He was actually why and how can he connect patients at a deeper level? Last time maybe at a very superficial level, but go to it, you know exactly what the patient goes through. So this is a book I thought I knew, and his stories is very powerful as well. What we want to do is, among all the culture, the patient partnership culture should be as strong as it can be. So here we have patient partnership culture should be so because it's part of the culture relating to improving patient safety. We have also looked at staff culture, make sure that our staff culture wellness is there. At the same time, we wanted to bring them together, right? We have the annual Singapore Patient Advocacy Connection, and we bring together all our healthcare, all our patient organizations, healthcare staff. And this year, we actually look at the care pledge. This is a care pledge, which I think we have the video here, which you can see. It's very important because both the patients and the staff pledge together to improve healthcare. There is this commitment towards each other and to the system as well. And we wanted this to be part and parcel. So we are getting more and more patient organizations in Singapore to so-called commit to this care pledge itself. Right? So this is the patient healthcare team care pledge. Many organizations have actually looked at it itself. And we want to bring all this together under our platform. So we launched the SingHealth Center for Person-Centered Care with Esther, Stan, and various aspects of the concepts to come together so that we can treat our patient, manage our patient better, and be able to partner the patient better as well. At the same time, we are forming the Alliance of Patient Organization in Singapore to have more synergy as well. So I just want to end with a couple of this. Basically is that in the past we are looking at the disease in care because we are short of resources maybe, and maybe we don't have the various enlightened views. And then now we're looking at a person in care. How do we treat the person with the disease is actually very important. And now how can we partner them in their care? Because when we partner them in their care, there are a couple of things. Number one, that we need to share power with them. We need them to be activated so that our care and the safety can be highly improved. Right. So basically, patient partnership culture together with the staff teamwork culture are strong if you want to have a good patient ecosystem, good patient safety ecosystem. So this on my last slide, basically focus on disease care to person in care as in our ESTER best practice. Listen to their stories, patient stories. Be partners in care, like in SPAN, which is our patients, Singapore Patient Advocacy Network, and to co-produce care. So I thank you very much for your attention. Thank you.
Thank you very much for that very wonderful presentation. Okay, we learn from our also we learned that we need to insert the deliver the very qualified healthcare for every remote area in Indonesia. That's very wonderful. Okay. Next, I will invite any question from audience for our distinguished speaker, please. Okay. Okay, thank you, Dr. Adrian. From Rumah Sakit Universitas Airlangga or Airlangga University Hospital.
I would like to answer in Bahasa. Yeah. Sorry, Profesor Tan, speaking Bahasa. Dokter Nia, salam kenal. Saya Adrian. Saya dari Rumah Sakit Airlangga. Saya dokter kebidanan dan kandungan. Kebetulan saya manajer pelayanan medis dan sekarang saya anggotanya di pusat riset. Menarik sekali tentang kebijakan-kebijakan yang Ibu sampaikan tadi. Sebenarnya saya ini agak iri dengan stunting. Kenapa? Yang pertama, saya bergerak dalam bidang advokasi masalah policy untuk maternal. Namun, dan saya termasuk salah satu perumus untuk perpres penurunan AKB, tapi sampai sekarang masih menggebu. Jadi mohon dibantu untuk disundulkan. Nah, tapi sementara stunting ini luar biasa. Kemudian sekarang ada isu lagi mental health yang Ibu sampaikan. Sementara banyak hal-hal mendasar termasuk patient safety, TB, maternal, dan neonatal ini masih belum muncul gitu. Mohon pendapat dari dokter ke depan seperti apa ini? Apakah masih bisa ada peluang khususnya karena kita bicara tentang patient safety ya? Karena kalau kita konteksnya bicara patient safety, Indonesia ini sudah punya komite nasional ya, kalau nggak salah, komite nasional patient safety. Kemudian ada akreditasi atas bagaimana peran dari Kemenko dan kementerian terkait untuk mendorong ini untuk yang patient safety. Kemudian untuk yang maternal, bagaimana peran dari Kemenko juga untuk agar kesehatan maternal dan neonatal yang merupakan salah satu komponen indeks pembangunan manusia itu juga lebih diperhatikan. Oke, terima kasih dokter.
Pas karir saya yang lalu itu memang BKKBN, tapi saya shifting, alhamdulillah kemarin dapat amanah untuk menduduki posisi asisten deputi peningkatan pelayanan kesehatan, dan apa yang dokter sampaikan itu memang sudah menjadi PR di Kemenko PMK. Mohon maaf tadi memang saya mencontohkannya mental health karena pandemi ini menghantam seluruh lapisan dok, terutama anak-anak, anak remaja. Jadi jangan salah ketika anak kita pendiam, mungkin aja ada gangguan. Anak kita pendiam ternyata dia juga bukan hanya secara mental, tapi juga fisiknya dia mengalami gangguan. Dan ini not to be filed dok, menjadi catatan saya untuk lebih mengendorse terkait dengan kesehatan ibu dan anak. Kebetulan memang kami juga sedang berproses dok untuk membuat turunan rancangan peraturan pemerintah 1166 pasal yang sedang kita bahas dok. Hari ini pun juga saya sebentar lagi sudah dipanggil-panggil karena kita sedang harmonisasi terkait dengan pasal-pasal di turunan Undang-Undang Kesehatan nomor 17 tahun 2023. Nanti untuk rancangan perpres KIA-nya dok memang sudah, cuma memang kemarin karena ada beberapa hal yang harus kita siasati, kita lihat bersama, itu memang agak tertunda. Dan memang sangat sedih sih dok, kami sendiri di level Kemenko PMK kalau lihat helikopter view-nya di beberapa kementerian lembaga ini memang stunting selalu menjadi yang penting gitu kan. Cegah stunting itu penting kan, tagline-nya seperti itu. Tetapi bisa disampaikan tidak mengecilkan dok yang lain, kesehatan ibu, KB. Sekarang juga kita tahu bahwa KB juga gaungnya nggak begitu terdengar. Seperti apa? Anak-anak sekarang jangan salah, mereka langsing-langsing ternyata begitu ini mereka punya infertility, mereka punya gangguan kesuburan, mohon maaf. Tetapi ini memang kenyataannya. Banyak anak-anak yang hormonal imbalance dan ini juga yang akan kita coba siasati, kita akan sikapi dan mungkin nanti future plan-nya kita bisa bekerja sama. Kebetulan di Kemenko PMK sendiri, kenapa tadi saya sangat-sangat concern terhadap mental health? Memang kebetulan ini PR dari Presiden loh. Jadi PR di mana Presiden itu sangat fokus terkait dengan pembangunan rumah sakit jiwa prioritas. Jadi ada 7 provinsi prioritas yang harus dibangunkan rumah sakit jiwa. Dan ini bukan simple task to do, karena rumah sakit jiwa ini kan kalau hanya spesial untuk rumah sakit jiwa nggak nutup untuk operasional. Nah jadi memang harus ada strategi-strategi di mana kemarin juga kita melihat 60%-nya masih jiwa, 40%-nya dibuka dong untuk umum. Jadi masih ada pelayanan-pelayanan umum. Dan kita nanti mungkin bisa sinergi dok, hal-hal apa yang bisa saya lihat, yang bisa kita endorse tadi yang memang disampaikan itu sudah memang menjadi PR. Dan nantinya ini bukan hanya ya dok yang selesai di simposium ini, tetapi ada aktiviti-aktiviti selanjutnya karena kalau yang seperti ini nih dok, ketika kita bertemu baru saya dapat informasi. Kebetulan kalau dengan UNAIR bukan kali pertama, saya 2019 ketika acara ISOF di Gold Coast, saya diundang menjadi presenter di situ dan baru pulang beberapa bulan yang lalu kita sedang mengejar stem cell untuk kesehatan Indonesia. Jadi sebagai informasi stem cell itu mahal. Jadi kalau orang Indonesia yang kaya biasanya lari ke Singapura, Prof. So they use the stem cell process in Singapore. But nowadays that we want to expand the stem cell into the some hospital, government hospital, dan salah satunya UNAIR. Jadi memang ini kolaborasi yang memang bukan hanya bicara patient safety, quality, tetapi juga in term of many other sektor kesehatan yang mungkin nanti bisa kita gain bersama. Mana-mana yang bisa kita prioritaskan. Tapi in term of KB, KESPRO, beberapa waktu ini kan kita sudah punya banyak ya metode kontrasepsi, ada implan 1 batang, ada kontrasepsi suntik 1 bulan, ada pil menyusui yang sebelumnya hanya pil kombinasi. Dan ini bisa menjadi pilihan dari masyarakat dan tentunya perempuan mempunyai hak yang lebih besar untuk memilih metode kontrasepsi yang ada. Saya juga sebenarnya concern ketika bicara kontrasepsi, bicara tentang kesehatan reproduksi karena ini bukan hal simple. Mau ujung-ujungnya bicara stunting, tapi ini ibunya kalau udah ada masalah gimana mau nganuin anaknya. Ini ibunya kalau mau punya anak, kalau gimana mau punya anak jangan kan stunting. Tapi kalaupun ibunya nggak sehat, bagaimana dia proses untuk mendapatkan keturunan. Dan ini saya rasakan sendiri sebagai seorang perempuan yang akhirnya seeking for help. Saya harus bertemu beberapa dokter OGIM, sampai pernah ke Singapura juga untuk melihat bahwa ternyata saya punya imbalance hormonal yang tidak mudah untuk disembuhkan. Jadi nanti kita follow up oke habis ini insya Allah nanti saya akan share lebih banyak informasi dan one thing for sure ini bukan pertama kali, nanti untuk kedepannya kebetulan di Kemenko PMK selalu ada rapat koordinasi dong. Nah ini akan menjadi catatan saya untuk mengundang dari FK Unair dari pusat-pusat studi supaya kami juga mendapat informasi yang lain, karena biasanya kalau dapat dari dinas kesehatan, dari Kementerian Kesehatan ini kadang-kadang sudah bagus-bagus, karena yang dilaporin ke Menko kan kepada Prof Muhajir, kebetulan beliau itu sangat-sangat bijaksana, beliau sangat orang baik sekali, ini yang bagus-bagusnya. Tetapi ketika kita turun ke lapangan, ternyata baru lihat obat nggak ada, kontrasepsi nggak ada, jangankan untuk bicara stunting kan, ya bicara keluarga stunting dikasih telur, boro-boro orang telurnya dari makan anak stunting dimakan bapak ibunya, yang sehat bapak ibunya bukan anaknya. Jadi ini contoh. Jadi saya tuh selalu dicolek sama Pak Menko, ini coba dilihat lagi lebih komprehensif. Which activity ataupun juga tindakan-tindakan yang harus kita ambil sebagai kalau saya selalu bilang helikopter view-nya itu kan ada di Kemenko PMK. Jadi kalau Pak Menko selalu melihat bahwa ayo kita listing mana-mana yang menjadi prioritas layanan kesehatan yang dapat diberikan kepada masyarakat. Mungkin itu dong tanggapan sedikit dari saya. Terima kasih.
Terima kasih. Dokter bagaimana? Sudah jelas, clear? Mantap. So this is very clear answer because Dr. Adrian asking about the policy about the maternal and the neonatal from government. So Dr. Nia tell because mental health now is become our priority after COVID, but of course after this we have a project also with the maternal and neonatal. Okay, for the question number second from our audience from the Zoom. To Prof. Tan, maybe you can explain how to reduce the stigma from the patient voice, because in Indonesia, the patient voice is something bad for institutions, something it will make the healthcare institution become bad thing. So how you reduce the stigma for the patient voice? Yeah, patient voice. So the patient can share their experience more and more without harming the healthcare institution.
Right. I think patient falls. I think basically in Sing Health we do have a committee and that is look at the falls relating to that. And it is important to have the information not just from the staff, but from the patient. And that's why we also engage our patient advocacy network for those who come together to be able to look at how we can reduce falls. Actually, for falls, there is another counter indicator, because one of the ways to reduce fall is to tie everybody down to the bed. Then you have no falls. But what you have increase in the bed sores, increase in, because you don't encourage mobility. This in fact is actually even more important, because once after the operation, you want to mobilize the patient as much as possible so that they can recover better. So it's actually between this. So we realize sometimes falls can be reduced to a certain level, but it cannot be completely reduced, right? We want to make sure that if there is a fall, they will be able to react to the fall easily and the fall will not be so serious. So we look at various ways to try to mitigate the falls, as well as of course to prevent the fall, but up to a certain level. We do not want to restrain every patient to the bed. So it's a dynamic balance, and I think everybody plays a part. The system, the culture, the patients, and the staff all should come together to find out to the optimal level where fall is kept to a minimum, and yet the patient is able to have mobility done as much as possible. Yeah. So it's a dynamic approach, and it's a holistic approach towards that.
Thank you, Doctor. Once more for Dr. Nia. You have a lot of questions. Okay. We have a question. How about the making policy for health? is it collaborate with the patient and community or family? And could you explain how you collaborate with the community and also with the patient? Thank you.
Ya, bicara kebijakan ini susah-susah gampang. Tadi yang saya paparkan, policy ini bisa dari top to down or down to top. Jadi biasanya dari kunjungan-kunjungan kerja yang dilakukan oleh pemerintah, terutama pemerintah pusat, biasanya kita langsung melihat bahwa ada policy yang harus kita ambil melihat dari situasi yang ada di masyarakat. Lalu kebijakan dari atas tentunya tidak bisa kalau misalnya Kementerian Kesehatan atau Kemenko PMK mengambil satu langsung kebijakan utuh, tidak. Tentunya kita akan ada base of evidence, jadi semuanya berbasis data. Dan biasanya yang akan dilakukan gathering seperti ini, kita mengundang semua pakar. Kita juga melihat bahwa misalnya saya contohkan juga tadi mental health, apa sih sebenarnya yang menjadi isu di mental health? Oke, aksesnya, rumah sakit jiwanya. Lalu apa nih yang pemerintah harus buat? Berarti kita harus menyiapkan aksesnya. Lalu bicara akses bukan hanya rumah sakitnya saja, rumah sakit nggak ada dokter jiwanya juga percuma, rumah sakit tidak ada obat dan farmasisnya juga percuma, jadi harus ada dilakukan step-stepnya. Dan ini biasanya multi-sectoral approach yang akan kita lakukan, mengundang dari lintas sektor terkait, bukan hanya dari pemerintah pusat, tetapi juga pemerintah daerah, akademisi, dan juga tentunya patientnya sendiri. Seperti apa sih sebenarnya yang harus mereka lakukan ketika kita bicara mental health? Jadi konsep rumah sakit jiwa ataupun juga sekarang kan berubah ya, kita mau menggunakan community mental health center, di mana kita tidak mau menstigma. Jadi stigma setelah keluar dari rumah sakit jiwa ini yang sulit. Sama seperti kalau kita keluar dari rumah sakit jiwa, terus orang pasti akan, wah jangan-jangan dia benar gila. Langsung seperti itu stigmanya. Jadi kita mengurangi stigma seperti itu. Lalu kita buatnya seperti apa? Rumah sakit jiwa yang modern, yang green, yang banyak tanamannya. Jadi nggak orang mungkin nanti kita juga akan shifting untuk mungkin berubah. Tidak jadi rumah sakit jiwa, rumah sehat atau rumah mental health. Jadi tidak lagi dengan stigma rumah sakit jiwa. Contoh di Jakarta kita tidak bicara lagi rumah sakit, tapi kita bicara rumah sehat. Karena itu kan ketika kita bicara sick, kita nggak mau dong sakit, kita maunya sehat. Jadi itu menjadi doa dan mungkin nanti shifting dari kebijakan yang tadi yang dipertanyakan bahwa memang tidak mudah membuat kebijakan. Apalagi ketika kebijakan itu terimplementasikan ke masyarakat, pasti akan banyak pro dan kontra. Ini saya contohkan sistem kesehatan nasional 6 pilar yang harus kita tekankan. Contoh saja e-shift dokter gitu kan, anaknya nggak mau, dia pulang, benar-benar pulang, dia e-shift wahana dikocok. Tapi begitu dia tahu dia dapat di Papua, dia bisa pulang. Kenapa? Anak yang tinggal di kota besar, anak yang biasa mengenyam semua fasilitas mewah, tiba-tiba harus tinggal di Papua, dan dia tidak berpikir apa-apa, ya udah nanti paling juga mundur 6 bulan segala macam. Dan kita harus mencari kebijakannya seperti apa nih supaya dokter-dokter dalam tanda kutip di daerah terpencil, perbatasan dan kepulauan ini tetap punya dokter. Jadi saya baru contohin dokter, belum apoteker, belum nurse, belum retaker yang UKM PPD ya dok, banyak sekali gitu kan. Berapa banyak anak yang stres karena harus apa? Mengulang ujian, farmasi, apoteker, itu juga. Ya, dan itu tidak mudah untuk pemerintah. Mau dibuang UKM PPD, kita pengen punya quality of the health providers, which is needs the requirement. But if it's like we put the UKM, the national board exam, we have lots of retakers. Jadi ini benar-benar we have to make simplify bagaimana satu kebijakan ini bisa inline untuk semua. Jadi tidak mengurangi quality, increasing the quality, tetapi juga tidak menyusahkan orang-orang yang memang dealing dengan health providers atau yang sedang memang menjadi healthcare providers. Mungkin itu dari saya.
Thank you, Dr. Nia. We have 2 questions again. For the first, from Dimas. Dimas is from Yayasan Pasien Immunodeficiency Premier Indonesia. So this is for patient immunodeficiency in Indonesia. We are happy to hear that Indonesia is moving to provide stem cell as one of key therapy for immunodeficiency patients. Will Indonesian government support the patient for PID management for intravenous immunoglobulin replacement, and curative therapy such as stem cell. As of now, both it is not covered by BPJS.
Ya, memang belum. Stem cell itu bukan murah, Bapak Ibu sekalian. Jadi saya kemarin kunjungan ke Rumah Sakit Dr. Sutomo bersama Bapak Diro dan jajaran. Beliau mengatakan tidak mudah, tidak murah melakukan itu. Jadi memang ketika kita mau shifting kebijakan, pembiayaan itu untuk di-cover sama pemerintah, kita harus turun. Saya turun sendiri, saya melihat langsung apa sih yang sebenarnya bisa dipakai ketika bicara stem cell. Ternyata menghilangkan nyeri, meredakan nyeri aja bisa. Saya bilang, wah kalau kayak gitu saya nggak usah operasi spine surgery, 350 juta dok saya operasi itu. Dan itu waktu itu saya memang karena in pain, saya tidak berpikir lagi BPJS Kesehatan untuk di cover. Jadi saya informasikan BPJS Kesehatan sangat membuka untuk pemerintah berdiskusi mana-mana pembiayaan bisa di cover. Tetapi juga mereka punya limitasi, tidak bisa semuanya harus kita cover sekarang. Jadi kalau bicara stem cell, in the future, bismillah, mudah-mudahan dalam waktu dekat setelah kita kunjungan kemarin ke Sarjito, kita ke Sutomo, terus juga kita ke Karyadi, karena kita RSCM, kita melihat bagaimana minat animo pasien terkait dengan dibutuhkannya stem cell untuk layanan kesehatan. Jadi memang diskusi panjang ini masih terus berlangsung, bukan hanya dengan BPJS Kesehatan, tapi juga dengan BPOM. Sertifikasi halalnya seperti apa ketika bicara barang ini, gitu kan? Lalu kalau dipakai di orang lain ini gimana? Jadi Bapak Ibu, Indonesia ini cantik, Indonesia ini memang unik kalau saya bilang ya. Kita sudah mencari gitu solusi, tapi nanti ada saja berbenturan dengan sisi agama. Dan tidak mengecilkan karena kita adalah negara besar, negara muslim terbesar. Jadi hal-hal yang sertifikasi halal, sediaan produknya seperti apa, nanti nomor izin edarnya bagaimana, ini menjadi PR aja. Tapi saya selalu optimis bahwa apa yang kita niatkan insya Allah walaupun memang pelan-pelan tetapi insya Allah nanti akan menjadi concern dan pembiayaan masuk dalam tahapan pembiayaan pemerintah. Mudah-mudahan sih tahun depan kita mulai berproses, tidak semua tetapi untuk beberapa treatment terkait penggunaan stem cell ini bisa kita prioritaskan.
Amin. We hope next future BPJS will cover for stem cell for our friend from immunodeficiency patient. Okay. The next second question for Prof. Tan. Will there be any knowledge transfer with our counterpart in Singapore, whereby bone marrow transplant is one of the best in class in Southeast Asia? Thank you very much. Bone marrow transplant. Yeah.
So, bone marrow transplant, I think in our hospital, KK Hospital, we do the bone marrow transplant with quite good results. And I think it's definitely going to share, we will share it. And, so you think about the collaboration. Yes, I think it's possible. You can send me an email, then arrange to see whether there could be some kind of visits with each other so that you can learn the practices relating to that. And as we got, in medicine, there's a lot of healthcare kind of treatment coming out. They are new, they can be innovative, but they are new and they can be expensive. And usually it is important at the ministry level to be able to evaluate them. And maybe evaluate them is based upon evidence-based medicine and also the cost relating to that therapy. And nowadays we do begin to bring patients in to be able to help out with part of assessment because the patients are actually the users and they have knowledge relating to that. And it is important because if, for example, if the care is very new and there's no evidence or very little evidence relating and it's very expensive, it is important to have regulations relating to it. So sometimes we are not sure the Ministry of Health put it under the research setting. Because can you do it under the research setting to see whether it does prove? And only when there's evidence is there, then we'll consider whether to be able to support that therapy itself. Initially, it's very expensive. It has to be that who has the resources to pay for sometimes philanthropy and all that. But only when the cost is reasonable and it has a greater effect for the population, only then the ministry comes in to say, yeah, maybe we put that as part of the treatment that we might want to subsidize that. So it is important because it's for healthcare quality and to be able to reduce healthcare costs.
Thank you for the answer. Oh, this is the last question. Okay, please, Dr. Ang.
Maaf, saya akan bertanya dalam bahasa Indonesia. Mungkin bisa dibantu translate oleh ibu saya supaya nanti yang lain juga bisa semua. Mungkin semuanya pelan-pelan. Jadi tema pada simposium ini itu keterlibatan pasien. Menurut saya patient safety itu baru dirasakan oleh pasien ketika mereka mendapatkan insiden. Jadi pasien itu enggak, ketika masuk rumah sakit mereka enggak merasakan ada namanya patient safety-nya. Nah di sisi lain open disclosure itu juga enggak mudah karena kita ketika mau melaporkan suatu kondisi insiden pasien itu bisa jadi pelakunya atau yang terlibat itu tidak dikasih. Nah pertanyaannya kepada Prof Tan, bagaimana rumah sakit secara teknis dan mudah itu bisa melibatkan pasien terkait keselamatan pasien? Karena menurut saya paling mudah ketika pasien itu ada menyampaikan sesuatu yang sifatnya komplain itu, mereka cenderung komplainnya terkait alurnya, fasilitasnya. Mereka jarang menyampaikan keluhan terkait keselamatan pasiennya. Padahal di rumah sakit itu program keselamatan pasien sangat dijunjung tinggi ya, tapi menurut saya pasien nggak pernah merasakannya. Nah, bagaimana sistem yang harus dibangun oleh komite mutu rumah sakit supaya pasien itu bisa mengetahui bahwasanya dia merasa mengikuti program keselamatan pasien yang dibangun. Jadi tidak melulu hanya terkait fasilitas atau hal yang dirasakannya, sehingga ketika terjadi sesuatu yang menjelang insiden dan sebagainya, mereka bisa langsung menyuarakan, sehingga komplain itu menjadi lebih objektif daripada pelaporan. Kita mengharapkan pelaporan dari pemberi pelayanan. Itu maksud saya, mungkin bisa dibantu translate ke Prof. Terima kasih.
Prof. Our condition in Indonesia, patient safety, this is something that didn't feel by patient until the incident happened. Healthcare, especially in a hospital, to make the patient can deliver their complaint objectively without complaint for the facility, for the response time, but in the whole objective for the patient safety part.
Yeah. So you're talking about how we can improve our system so that it will be the best for the patient, and yet the patient would be able to, instead of patient complaining after a certain event, but they actually power to do this. And that's the whole essence of it, is called patient partnership itself. Because we see the patient as a stakeholder and as a patient, and we need to assess the patient. Some patients are very knowledgeable, some patients are not knowledgeable, some patients are not compliant. So as the healthcare system should be able to recognize, here we are dealing with a patient that is not aware of certain things, then we should give more information, we should look at ways to improve their compliance. And here we have a patient who is super activated, they are very activated, they know about it, they want to know about certain things, so we give them a different type of information to know their rights. They also want to be able to help out, they feel that, and for example, they want to be able to spot if there's any problems related to that. We should give them the channels to say that, hey, your system maybe is more likely to end up with a problem. You know, your doctor doesn't seem to be able to practice hand hygiene. I was able to do that. So different strokes for different folks of patients. We should allow that. The system should be able to allow that. And that's why now we sort of look at patients differently and see what their needs are. And the needs of patients are different. And when the incident happens, right, that is the whole issue of the open disclosure. Some patients, what they want is for the institute to say, I'm sorry that this thing happened, and that you all will learn from this. But if we try to hide from the patient becomes very angry, and the patient will take a lot of drastic actions that would not help your institution in terms of publicity, in terms of your care that is delivered. That's why we need to work at patients, and there's no simple answer, we work at patients at all levels and with different kind of patients. And that's what we call a good patient partnership system that is different from last time where we look at their disease, or different from last time that we just talk down with them and say, we know best, we just tell you what to do. And when there's a problem, okay, you tell me, then I will try to do something, but they become part of the process. So it takes time to evolve. And in Indonesia, there are different communities, right? So maybe in Surabaya, your hospital system here in Surabaya, the patients are more educated. It might be slightly different from that if you're going to the rural areas where the total don't even know, do you know what healthcare is, whether even they should come. So it's a different strategy altogether.
Terima kasih. Sudah jelas, Dr. Am? Okay, baik. I think this is the end of our session. Before it, I will give the end of the session to the Master of Ceremony. Please, Master of Ceremony.
With a token of appreciation in the form of a certificate. Now, with a great honor, I invite Ibu Ika Pratiwi as M.Si, as the Manager of Collaboration in Center of Excellence, Patient Safety and Quality, to give the certificate to the speakers. Semoga tepuk tangannya dari para peserta. Selanjutnya penyerahan sertifikat oleh Ibu Ika pada pembicara, pada pembicara. Sekarang ini mungkin bisa kembali untuk masing-masing. Ya. Our event. Now, as
as we delve into a moment of respite, it's my pleasure to announce that we have 5-minute break. Please be mindful of the time as we will resume our program shortly. Thank you for your attention.
I pledge to ensure safety of all and stamp out abusive and rude behavior.
I pledge to communicate respectfully and clarify concerns.
I pledge to show you understanding and treat you with kindness.
I pledge to provide clear, timely, and complete information for shared decision making.
I pledge to be responsible and play our part in this healthcare journey.
I pledge to ensure the safety of one another and trust in professional standards.
We can make healthcare better and safer.
I pledge
I pledge
to ensure safety of all and stamp out abusive and rude behavior.
I pledge
I pledge
to communicate respectfully and clarify concerns.
I pledge to show you understanding and treat you with kindness.
I pledge to provide clear, timely, and complete information for shared decision making.
I pledge to be responsible and play our part in this healthcare journey.
I pledge to ensure the safety of one another and trust in professional standards.
We
can
make healthcare better and safer.
Sobat Keselamatan Pasien. Saat ini atau nanti, setiap orang pasti membutuhkan pengobatan untuk mencegah atau mengobati penyakit. Hayo, siapa yang biasanya membeli resep ke apotik, ambil obat, dan buru-buru pulang? Sepertinya saya. Hehehe, aku. Saya juga. Eits, tunggu dulu. Kamu bisa loh menjadi pasien atau keluarga pasien yang aktif. Pasien dan keluarga pasien diharapkan berperan aktif dan menjadi mitra petugas kesehatan untuk menjamin keselamatan pasien. Obat-obatan terkadang menyebabkan bahaya serius jika 1. Dikonsumsi secara tidak benar, 2. Tidak dipantau secara memadai, atau 3. Disebabkan oleh kesalahan, kecelakaan, atau masalah komunikasi. Kesalahan pengobatan menyebabkan setidaknya 1 kematian setiap hari dan membahayakan sekitar 1,3 juta orang setiap tahun di Amerika Serikat. Secara global, biaya yang terkait dengan kesalahan pengobatan diperkirakan mencapai 42 miliar US dollar per tahun, atau hampir 1% dari total pengeluaran kesehatan global. Ayo cegah dan kenali kesalahan pengobatan dengan menerapkan 5 momen untuk keamanan pengobatan. Tanya dan temukan jawabannya ketika mengunjungi dokter, dokter gigi, perawat, atau apoteker. Mengunjungi fasilitas pelayanan kesehatan primer atau apotek. Masuk dan keluar dari fasilitas pelayanan kesehatan. Dirujuk ke fasilitas kesehatan lain. Dipindahkan ke fasilitas pelayanan kesehatan lain. Menerima pengobatan dan perawatan di rumah atau home care. 5 momen untuk keamanan pengobatan. 5 moments for medication safety. Pertama, memulai pengobatan. Tanya dan temukan jawabannya. Nama obat dan fungsinya, risiko, dan efek samping obat. Kedua, mengkonsumsi obat. Tanya dan temukan jawabannya. Waktu dan frekuensi minum obat. Penanganan jika terjadi efek samping. Ketiga, menambah obat lain. Tanya dan temukan jawabannya. Perlu atau tidaknya pengobatan lainnya. Interaksi obat dengan obat lainnya. Keempat, evaluasi pengobatan. Tanya dan temukan jawabannya. Lama waktu pengobatan, tetap atau tidak perlu minum obat jika tidak dibutuhkan. Kelima, menghentikan pengobatan. Tanya dan temukan jawabannya. Batas waktu menyelesaikan pengobatan. Kemana harus melaporkan jika menyelesaikan pengobatan karena efek yang tidak diharapkan. Kesalahan pengobatan dapat menyebabkan kejadian yang tidak diharapkan, mengurangi kemanjuran obat, atau menyebabkan rawat inap atau kematian yang seharusnya dapat dicegah. Karena keamanan pengobatan sangat penting, besok-besok jangan terburu-buru pulang ya. Pastikan semua sudah ditanyakan dan dapat jawaban yang jelas. Salam keselamatan pasien. Share and save lives.
Integrity, rigor, independence. At ECRI, these are not just words. They're guiding principles we've followed for more than half a century as we've worked to protect patients and advance evidence-based healthcare worldwide. Transformational changes in healthcare are giving rise to new and urgent challenges around safety and quality of care. Critical decisions about treatments, coverage, cost, and health policies must be guided by a source of knowledge that is trustworthy, unbiased, and based on the best available evidence. For tens of thousands of healthcare leaders around the world, ECRI is that source. ECRI's undisputed credibility stems from its relentless commitment to independence and integrity, and the strictest conflict of interest rules in the healthcare industry. Today, we recommit to those principles and to our role as the most trusted voice in healthcare. Join us as we shape healthcare, empower and assure healthcare leaders, and protect patients worldwide. Integrity, rigor, independence. It's why we're the most trusted voice in healthcare.
Sobat Keselamatan Pasien. Saat ini atau nanti, setiap orang pasti membutuhkan
selalu dukung inklusivitas di berbagai bidang. Katakan tidak pada bully dan diskriminasi pada penyandang disabilitas.
Halo, saya Nia Reviani dari Pusat Riset Keselamatan Pasien Universitas Airlangga. Pada kali ini kita akan belajar tentang berpartner dengan pasien dan keluarga dalam pelayanan kesehatan. Keselamatan pasien merupakan salah satu prioritas utama dalam pelayanan kesehatan. Melibatkan pasien dan keluarga dalam pelayanan merupakan salah satu strategi dan intervensi yang dapat meningkatkan kualitas pelayanan serta mencegah terjadinya insiden keselamatan pasien. WHO melalui program Passion for Patient Safety sangat mendorong keterlibatan dan pemberdayaan pasien dan keluarga dalam pelayanan kesehatan. Di antaranya, hal ini akan meningkatkan kemampuan pasien dan keluarga untuk pengambilan keputusan dalam menentukan perawatan yang paling sesuai dengan mereka.
Terdapat setidaknya 3 cara untuk meningkatkan keterlibatan pasien dan keluarga. Yang pertama, mendidik pasien melalui komunikasi verbal dan tertulis. Sebagai contoh, rumah sakit bisa membuat leaflet, video, atau media penyuluhan lain dan meletakkan di tempat yang mudah diakses oleh pasien. Yang kedua, rumah sakit juga harus mendorong pasien untuk mengajukan pertanyaan dan mendiskusikan perawatan mereka. Dan yang ketiga, dorong pasien untuk memberikan umpan balik dengan cara menanyakan pengalaman mereka setelah menggunakan pelayanan kesehatan. Dengan keterlibatan yang lebih tinggi, kondisi kesehatan pasien akan meningkat, pelayanan akan menjadi lebih aman dan keselamatan pasien akan terjaga. Salam keselamatan pasien. Share and save lives.
Something just didn't feel right.
We had so many questions.
They didn't listen to us, again and again.
No one told me what went wrong.
We all have the right to safe healthcare.
Each one of us.
Most of the harm caused to patients can be avoided.
Safety starts with us.
We have the right to ask questions
and to get answers.
To express our opinions and concerns.
To know if something went wrong in my care.
When I include patients and families as members of the health team,
care becomes safer.
When I listen to my patients.
When we are transparent.
When we learn from patients' experiences.
When we make decisions that include patients' voices.
When we partner with patients and families,
we save lives. When I am hurt, I can make a difference in my own care
and the care of others.
Together,
we can achieve safer healthcare
for everyone.
Teman-teman pasti udah pada tahu kan Pusat Riset Keselamatan Pasien? Pusat Riset Keselamatan Pasien telah berdiri sejak tahun 2018 dan mempunyai visi besar untuk berkontribusi dalam peningkatan kualitas pelayanan kesehatan dan keselamatan pasien di Indonesia. Di bulan September tahun 2023, Pusat Riset Keselamatan Pasien mendapatkan hibah Kementerian Pendidikan, Kebudayaan, Riset dan Teknologi untuk menjadi pusat unggulan di bidang mutu dan keselamatan pasien. Oleh karena itu, mulai tanggal 17 September 2023, Pusat Riset Keselamatan Pasien akan berubah nama menjadi Center of Excellence for Patient Safety and Quality atau Pusat Unggulan di bidang mutu dan keselamatan pasien. Nantikan sederetan aktivitas kita ya. Mari berkolaborasi untuk meningkatkan mutu dan keselamatan pasien di Indonesia. Jangan lupa untuk tetap share and save lives. Get ready, let's participate, let's collaborate.
Integrity, rigor, independence. At ECRI, these are not just words. They're guiding principles we've followed for more than half a century as we've worked to protect patients and advance evidence-based healthcare worldwide. Transformational changes in healthcare are giving rise to new and urgent challenges around safety and quality of care. Critical decisions about treatments, coverage, cost, and health policies must be guided by a source of knowledge that is trustworthy, unbiased, and based on the best available evidence. for tens of thousands of healthcare leaders around the world, ECRI is that source. ECRI's undisputed credibility stems from its relentless commitment to independence and integrity, and the strictest conflict of interest rules in the healthcare industry. Today, we recommit to those principles and to our role as the most trusted voice in healthcare. Join us as we shape healthcare, empower and assure healthcare leaders, and protect patients worldwide. Integrity, rigor, independence. It's why we're the most trusted voice in healthcare.
So, ladies and gentlemen, we will then move on to the second session of panel discussion, which will be moderated by Ibu Elida Zainina. Ibu Elida is a senior lecturer at the Department of Pharmacy Practice, Faculty of Pharmacy, Universitas Airlangga since 2002. She is also editor-in-chief of Journal Pharmacy dan Ilmu Kefarmasian Indonesia sejak 2016. She obtained her Doctor of Philosophy, PhD, of Faculty of Pharmacy and Pharmaceutical Sciences in Monash University, Australia, and graduated
welcome to the second session for the first International Symposium on Patient Safety and Quality. So we will have two inspirational speakers, and then I would like to invite the two speakers. The first speakers, I would like to invite Ms. Zahida Zahidi to welcome on the stage. And the second speakers, I would like to invite Dr. Nia Reviani to join us on the stage. Thank you for the two speakers. The first speaker will be Ms. Zahida Zahidi. Before she delivers the presentation, I would like to read a bit about her CV. Ms. Zahidi is currently a consultant at EZRI, and before I read brief about her CV, I would like to inform you what is EZRI. EZRI stands for Emergency Care Research Institute. It's a global independent authority on healthcare technology and safety, whose products and services help the healthcare community to improve quality, reduce costs, and achieve better outcomes across all care settings. Ms. Zahidi has obtained her bachelor degree in biomedical science with honors from Taylor University. She studied the bacterial growth and bioformation for opportunistic pathogens that can cause infection in the blood, lungs, respiratory tract, and in wounds in patients. She has over 7 years of experience in business development, strategy, and project management in the area of pharmaceutical and healthcare space. She also has heavily involved in the end-of-the-end process of bringing products from various therapeutic, including cardiovascular and so on. The EZRI itself is the only organization so far worldwide to conduct independent medical device evaluations with the North America and Asia Pacific laboratories. EZRI is designed an evidence-based practice center by the U.S. Agency for Healthcare Research and Quality. Additionally, EZRI is also a federally certified patient safety organization by the U.S. Department of Health and Human Services. And its currently international offices are located in Europe, the Middle East, and Asia Pacific. So, welcome to the symposiums, M.Si. M.Si will deliver a topic about patients engagement technology, best practices for healthcare. So, ladies and gentlemen, without further ado, I would like to welcome M.Si. Hasbiza Zahidi.
Hello, good morning everyone, selamat pagi semua. Thank you very much for the introduction. For also a quick shout out to the Center of Excellence of Patient Safety of Universitas Airlangga, Dr. Ingi, Professor Tan, and also Dr. Nia, the keynote speakers for today, and the rest of the participants online and also here at Bumi, Surabaya Resort. My name is Hasbiza Zahidi, or for short you can just call me Zai. As the topic about the patient engagement and the technology that used as part of the practices in healthcare, before I start into my topic, we always like to tell a bit of story about ECRI in a bit more details, a bit of storytelling. What are we? What do we do? So ECRI, as mentioned by the moderator just now, also known as Emergency Care Research Institute. That's how we started in the setting of emergency care. The picture here in my first slide is our founder, Dr. Joanne Nobel. When first he founded ECRI in around 1968 through a rather tragic incident whereby he had a patient. It was a 4-year-old boy being brought into the emergency care for getting the treatment health attention. But turned out while Dr. Joanne Nobel was trying to resuscitate the patient died because the machine was actually not functioning, and it had angered him because of such malfunction device could be placed at an emergency care setting, which is an important setting in hospital, and you could have malfunction devices being stationed in the emergency department. So he took his initiative to gather information about that device, what is the manufacturer, the model name, the serial number, and he documented it. And also he did that initiative to also search for other devices that are malfunctioned, similarly gather the information and documented it, and he tried to share to the health community nearby, but people were scared to share because they were afraid to get sued by manufacturers because the information was quite, as straightforward as it is. The transparency were, we're not blocked. Like if this device was from company A, it stated that company A. That started the core activity of what ECRI is all about, gathering information, evaluation, and documented it as a resource that is shareable with the whole community. And just a side story that our Dr. Joanne Nobel was a passionate physician for emergency care when he was one of the inventor team that invented the crash cart, also known as MH.KES cart or emergency cart, where you have the patient table, the IV fluid under one unit. So he was one of that team that actually invented this device. Just a short story a bit on the milestone. So when I mentioned that he wanted to publish the information, but no one really wanted to help. Eventually, he was able to get a fund from the Pennsylvania state. The background story of ECRI originated from Philadelphia, United States, which is under the Pennsylvania state. So the state fund that he got from there, he published that problem reporting network. And during that time, it should be around 70s, where also the US FDA Food Drug Administration focused only on drugs and food. There were not much of enforcement in medical device regulation. Hence, that's why you could have all these malfunction device lurking around in the hospital setting. And he was one of the people who bring forth the enforcement of medical device regulation in the US FDA when he testified at the US Senate hearings. And so, as I mentioned, that's the core activity of ECRI from the emergency care setting. It expanded, as you know, we go along 50 years of our establishment, we go beyond emergency care. So that makes sense for our company name now to be known as just ECRI, because we were no longer just focused on emergency care, we also look at other care settings within the health system. And throughout of our work, we get quite a few number of recognitions by the Agency of Health Research and Quality as one of the evidence-based practice center among the other 9 organizations like Johns Hopkins, Brown University, Mayo Clinic is also the evidence-based practice center. And when the US Health and Human Services established or founded a group of Patient Safety Organization or PSO, they recognized ECRI as one of the PSO due to the work that we do here at ECRI. And in 2020, we joined force, we actually acquired ISMP or Institute Safe for Medication Practices, which is also another non-profit organization that focuses on medication, safe medication practices. So you can imagine ECRI focus on medical device side, ISMP focus on medication and pharmaceutical safety side. So together we join force, we make up one of the biggest, actually we are so far the biggest PSO in the world that share these holistic resources in a more comprehensive of covering not just device but also medication practices. We are also a designated signatory to the ethical principles in healthcare due to the work that we do, whereby our work remains independent, neutral, not biased. We do not accept fund or money from manufacturers to do the evaluation for them, because that will instigate biasness and not make us a neutral party in our evaluation. So that makes our resources all based on evidence. And we are also, for ECRI Asia Pacific, is a member of ASQA, Asian Society for Quality in Healthcare. Yeah. So I believe that's what I would like to briefly. This is also a brief introduction of ECRI. There are a lot more work that we do, a lot more resources that we have. But since my first topic is about the patient engagement technology, I would like to just bring the focus into patient safety context of how that around the world the reports on patients' experience and patient safety are all being published and recorded. Nearly 3 million deaths recorded due to unsafe care, and among those unsafe care, more than 50% actually by an incidents that you could have prevent. And there are so much of umbrella of patient safety. There are a lot of components within it, but I would like to narrow down the attention to having patient engagement as the essential strategy to create a safer health system, as we believe that effective engagement between patient and providers, they can improve quality and safety healthcare, subsequently manage the healthcare costs and increase or improve on staff efficiency. It requires more collaborative effort among all stakeholders, with not just patients or their families, but also we would like to, not to say like touch, or like to gather or pull together organization leadership to create a better environment, more encouragement between providers and patients to have that more interactive or effective engagement in order to create better care plans which will lead to better health outcomes. The definition of patient engagement here is defined as the desire or capability to actively choose to participate in care in a way uniquely appropriate to that individual, cooperating with the healthcare provider for the purpose of maximizing the outcomes and also improving experiences of care. These are some of the statistics or a bit of the evidence that we at ACRI had gathered and acknowledge of how patient engagement, in fact, it does produce better health outcomes, with 3 times less likely for patients to have unsafe care, 2 times for patients more likely to seek medical care, and about 2% more, 2 times more, they are likely to stay adherent on medication. And thus, all this is, in fact, help to reduce hospital readmission rates. And these are the stakeholders that we at ACRI would like to highlight what it takes to create an effective patient engagement system. Now, patient and families is, of course, the key stakeholders, healthcare personnel, as well as organization leadership. So it's not just within patient and family and healthcare personnel or providers. The organization leadership should also have an active participation to help in improving patient engagement. Some key elements of patient engagement, in our view, it's more of the key is empowerment. So what does it take to elevate that patient empowerment? Is that the organizational leadership having some cultural shift or more policies or more SOPs that promote patient engagement and foster that communication skills that are effective to especially between providers to the patients, and importance of a sufficient health literacy. So it's quite important, I believe, from the previous sessions, from the previous speakers, talk about how sometimes patients, they were not very participative or not very engaging. That could be because of their background or health literacy is not quite sufficient for them to start asking questions. And this why patient engagement has to be a two-way kind of communication, so that even when they don't know how to ask, your doctor and providers, even the nurses, can be the one to initiate the first talk, or you ask more questions until the patient able to open up and tell more and ask more questions. That can improve in the health literacy. And the red highlights here that I would like to enforce or create that some awareness that sometimes we may be, we may be unaware that the patients and families, they have rights and responsibilities onto themselves. I think it's quite relatable to many of us, even for me. Some of my family members who are already old, they went to the government hospital for follow-up treatment. They think they just seperti menyerah diri aja. Pergi hospital, biar doktor yang check, biar doktor yang diagnose, ikut saja. Doktor prescribe apa, just follow. But they understand the medication, do they understand the diagnosis, do they understand the prognosis? Doctors also don't know whether they understand or they don't, or what they know or they don't know. So sometimes they feel embarrassed to ask, and it's suppressing their rights and the sense of responsibility, which should not be right in the context of patient engagement. So sometimes you have to probably give a bit more encouragement for the patient to say that you know you have right for your care plans. If you don't agree or you don't understand, you should speak up. So that kind of environment of openness and open communication that should be allowed in this context. And talking about the technology that can assist this form of engagement, we do have emerging, I would say, an emerging market segment within health technology. I'm aware that this also can be done without technology or with just paper and pen and sit together, just talk. But having technology to assist that engagement definitely can help a bit in the patient experience. Talking about it as an emerging market, as of date, the market size is actually big, quite $22 billion, with a CAGR growth of this market to reach in 2030 in 17.4% growth. So there is a need, there is a use of this type of technology in the healthcare market. In fact, in the US, 77% of the patients, they feel satisfied to use virtual healthcare visit or consultation. And then we also see a growing burden of chronic diseases arise in the geriatric population that can make use of this patient engagement technology to manage their health better. Also, just to give something like insight of this market, that it also rise to a growth of sub-segment of Internet of Medical Things that enables wearable device to monitor patients' health status in real time. Some AI integrated platform in the health applications that can give a personalized care for the patient, automation of hospital operations, and the mobile health apps. The objective of this technology, like what does it try to achieve in healthcare, is of course having empowerment for the patient, as this is engaging with them, adding an experience for a patient to engage more in their treatment care plans or discussion with their doctors to manage their health better. It does help to increase the care efficiencies, which in turn it can means that it translates into an efficient operational workflow of the hospital system, cost effectiveness, and since you are using technology, easy to monitor those conditions from time to time, it can have an early detection of any deterioration in patients' conditions. It helps to facilitate connection, help in building more communication between patients and providers, close that communication gap, and addressing it in some extent. It can also help in addressing staff shortages, as all the systems will be considered automated or digitalized. And if having so much of workload by using non-technology tools, with technology you can address staff shortages. Essential features in patient engagement solutions, you would see that it requires all the online billings, online appointment schedules, reminders. So most of the patient engagement technologies, they come with these features to assist health records, assist the patient to better monitor their health, get reminded on their appointments. So these are the essential features in patient engagement solutions. Some examples of the solutions are the remote patient monitoring, the handheld devices, example like the glucometers, the heart rate monitors, the ambulatory cardiac monitor, and also I think it's quite robust now, the adoption of the electronic health record system in most of the hospitals in this region, artificial intelligence integrated platform, the health apps, telehealth interactions, and one particular engagement that I found quite interesting is the patient engagement digital board. These are some of the examples. There are so many other solutions and software out there in the market that help in improving the patient experience, engagement for patients, but not just for patients, but also for the hospital healthcare system to make things more easy for them to manage the workload of reviewing patient data. But these are examples that I would like to share here, what are out there. And I think it's best for me to say that coming from a ECRI point of view, I am sharing this as an information, not to say that I am 100% endorsing this as the best method, because every technology adoptions also come with its challenges and risks, which we at ECRI also acknowledge, which I will share a little bit more about that later. Example of the RPM, it helps in facilitate the management of the disease condition, it monitor the health status. Some proven statistic that says these patients who have an access to a home blood pressure monitoring tool, they do have good outcome as lowered blood pressure from between 50% to 85%. So this is actually sharing with us a good feeling or satisfaction of using the home device to manage the condition. And over time, it can reduce with hospital admissions, readmission stay, length of stay, improve their behavior, make them more compliant, and all this information the providers also have access to those data information. And when they come for the subsequent appointments, they can discuss about their improvement. So that's part of the engagement there between a patient and the doctors. Next, other technology, this is a little bit more extensive within not just the patient phone, but also the entire healthcare system, whereby some manufacturers out there, like example Microsoft, they had created a cloud-based healthcare platform, where this type of platform, they gather as much data as they can store in cloud, and that access information is given to patients, providers, also hospital organization, and it also helps in easy or efficient data tracking acquiring. They have integrated features and easy data backup, and because this information the patient can also access. So it makes easy to monitor their status from time to time. And this integrated software, so-called, they also have artificial intelligence embedded in the system, where it can help in personalizing care for the patient itself. So that kind of information I find it would be very useful for patients and treatment care plans, because it is specific to the conditions itself. And in a way that when you can see the data in the system, you minimize the errors in patient identification, reviewing wrong information of the patient, because as it's stored in the cloud, that should be the correct data of the patient. So partly, the technology itself should be able to assist in a safe and quality care in that sense. And some personalized care digital platform, for example, that focus on specific disease care, like diabetes care, it similarly collects patient data for a specific disease. And within the system also, it has integration of AI into its workflow. So when you can interpret and analyze the data, you generate strategies for care plans, lifestyle changes, for the patients. It's a similar approach as the previous solutions, where you can also potentially reduce risk of wrong patient identification, reduce risk of data entry. Some of these applications, they mostly sometimes also key in data entry by the hospital, not just by the patient themselves. So in a way that can reduce wrong data entry. Electronic health records, or EHR, has been one of the technology solutions actively adapted in most of the healthcare setting in Malaysia, in Indonesia, of course in Singapore and other countries, as the drive or movement towards IR 4.0 digitalization automation requires electronic health record system that is believed to be more efficient to help in hospital workflow. And with admission from patient reach hospital, either to see doctor for the first time or to get admitted into the hospital, they will be guided to one system whereby all departments in the hospital is able to view only one type of information. So that reduce the potential for errors, as everybody is reviewing the same system and same data. And you can also record allergies or record medication, and so clinicians can be alerted about potential adverse events and can prevent more harm in patient care. And this type of solutions or technology, the patients can also access, and then they are able to engage with the providers to develop their care plans. And on this particular technology, is something that I've come across quite recently. I believe in developed countries may have this type of technology in their hospital care setting, but what does it do is that some hospital smart rooms, they have integrated some either a tablet or in-room TVs with information about the patient, their records, their appointment, their medications, and also it comes together with some entertainment. So it provide patients that access to their health record. At the same time, they get entertainment in a language they can understand. So this one, I think, is quite related to what Prof Tan mentioned earlier on minimizing fall. Try to manage that risk, because we everywhere in the world, I believe, identified patient fall as one of the top patient safety concern. So when patient is comfortable in their bed, they need something, or they want to call nurse for help, or they want to ask something, they can do so from their hospital room without going down from the hospital bed. So that can, when minimize movement, it reduces that risk for patient fall. And this is a point that I see when they're happy. I don't think anyone hospitalized would feel happy, but imagine they can be comfortable in their hospital bed, and it does create a good conducive environment for the patient, but also for the providers. Because if the patients are happy, they provide good feedback, it also should also motivate the healthcare providers. So it can of course help in the workloads, but when the mental health care part of the patient is well managed, then it is a good conducive environment where providers would also feel not so burdened when they're already burdened with so much of workload. And this is on some health apps. One of the technology that always assists in patient engagement. On the health general apps, they monitor well-being, they monitor the patient compliance. Some applications, they give access to specialists and clinicians through mobile phones. So one particular app that I know, they comes with a feature for online diary, or online journal. So when a patient subscribes to a package, they are assigned to a specific clinician or psychiatrist in that particular subscription. So let's say this patient is having some problem with mental health issues. They write down their thoughts in that journal, and when the psychologist notice or psychiatrist notice that those notes sound quite suicidal, the doctor will straight away call that particular patient and ask, how are you doing? Are you okay? So that kind of engagement is one of the examples that I found very, very helpful in this case to reduce that kind of harm and prevent the patient from going into do suicide. So there are such platforms out there in this world that very engaging, very helping the patient, that have that direct effect on the patient care. And of course, teleconsultation platform. I believe that starting from pandemic COVID-19, this market has totally boomed, where the needs for teleconsultation has dramatically increased. It provides immediate care and attention to patients, where it will definitely help in patient engagement for treatment and care, and it remains to be the solutions for assisting in patient engagement between the patients and the doctors. Right. Okay, and here is just to share about what's happening in the region. In Thailand and also Philippines, they are establishing a lot of platforms for patient access program in the hope that it can improve and elevate patient engagement for better health outcomes, and also to assist in improving the patient safety concerns in their countries. In Malaysia, we also have adoption on patient engagement application suite. Some connected health service with access to professionals, healthcare professionals at home, which is like home care, senior care, this connected health service, they are utilizing these patient engagement technologies to help managing the care. The platform is somewhat similar to the cloud-based platform where they gather data information, store in their system, and you can easily access during care, meeting the patients, and also some AI integrated platform that can help in generating the care plans for that particular patients in specific. In Singapore, there are some e-health solutions applications adopted by the Integrated Health Information System. We're having a similar intention of gathering information, track and record patient data, and have access for with patient during care, the data access for treatment plans and so on. And in Indonesia, we do have the digital transformation roadmap, which is, I believe, is quite robust in terms of its growth within the Indonesia health system, where adoption of EHR is very wide now, covering so much of these private hospitals in Indonesia, like Siloam, the Saimdarbi Care Indonesia, EMC, and some private hospitals, they take up the technology on remote patient monitoring to assist specific cases as part of the engagement and monitoring of the patient. Right, so as all those good side of the technology, which I also find very impressive, that exists in this context of patient engagement for safer and quality care, these are the identified risks that we actually acknowledge to be challenging or potentially risk in using the technology. Number one, the major point is having good accessibility. If there is no internet coverage, no Wi-Fi connection this technology can be quite useless because you still require that strong infrastructure of internet coverage for the technology to function. When you don't have connectivity, you can't access the information, and that can disrupt your care and your workflow. And of course, the question to the data security, data privacy, as one of the potential risks when you are storing big data, so much of information. What about the security? I would like to share a bit more on cyber attack. When your hospital system and data is not safely secured, you are exposed to malware attacks or hacking. One example I can share in one of the hospital in Germany, I forgot what's the hospital name. It was reported that the hospital was attacked by basically hacked. The entire system was hacked by a hacker, and they hold the patient data as ransom. Those data is valuable to them. They can sell in whatever black market for some amount of money. So they hold ransom to that data, and it caused the entire system to shut down. The hospital was not functioning. And coincidentally, that time there was an ambulance reaching that particular hospital, but since the emergency care is closed, they cannot accept any patient, that ambulance was forced to divert it to a nearer hospital, but the nearer hospital was 20 minutes away. So while the ambulance was on the way to that hospital, the patient actually died in the ambulance. So we notified this, acknowledged this as one of the technology hazard, one of the risks in patient safety. When you are exposed, hospital system exposed to cyber attack. Health literacy. If the patients do not understand the care plans, and if even by using of technology, the engagement is not fully effective, the treatment itself cannot be effective. So that how to have a better health outcome in this case. So having that first health literacy surely help in improving patient engagement. But as I say that this point shouldn't be a bummer or a downer, that you as a healthcare provider or at the healthcare professional sites, you can express or translate your care plans or what you wanted to express in a much simpler way so that your patient understand, and that can immediately help in the health literacy. As your patient to get engaged, they have to understand what's happening with them. And potential for diagnostic error, when we are too dependent on technology, for example like the AI, the artificial intelligence, they generate information based on the data that it can see, but what about the data that the system cannot see? So some patients comes with the underlying conditions may not be captured by the AI system, and that makes the diagnosis can be not 100% accurate. So you still require some thoughts about this, that it can also potentially lead to any adverse events. I'm not trying to put down the technology, but this is, I believe, one of the key things to be aware of, that too depending on technology is not 100% helpful as well in the patient care. Socioeconomic background and infrastructure to support engagement, patient engagement, technology implementations will not allow you to adapt faster, and in a way it won't be effective care plans. So some infrastructure not having a strong internet bandwidth, it's difficult to access the system as well. In this case, I think it is slowly starting with the governments, most of the governments in implementing patient health technology in their system. They are slowly, I believe, upgrading their health, their system. Like in Malaysia, we are now only starting to develop or upgrade our Wi-Fi from 4G to 5G. So when you're having 5G connection, then all the automations, all the access for big data, cloud storage can be more efficient in the future. And some some platform do not have that integration much with some of the system. So when you have a system that is not very integrated among other systems in a one healthcare setting, then your access data cannot be done properly, and also you can't utilize all the features, and thus can lead to having an ineffective care and inefficient workflow as well. Some key takeaways, I believe this would be my last slide for today, is that of all the technologies that you have heard, of all the risks that comes together, it is still key importance to engage. That also doesn't require technology actually. So from the providers to the patient, encourage the patient, and when you, with the objective to engage with them, is to make them feel happy or satisfied with you. So you touch about the experience of that patient. You can ask them how they prefer to be engaged, how they prefer to receive information, and so that they are in control also of their experience, as this engagement should be a two-way communications. And having a supportive infrastructure definitely help in adaptation, implementation of patient engagement solutions. This will have to be on a top-down approach through policy making or change of procedures, change of organization culture to have a supportive infrastructure to implement and set up or establish that system, so that you can start on having more fun or more satisfying experience for patient engagement. Of course, in this case, it doesn't just take few departments. You definitely need to involve your IT department, where you can consult or you build a good team of IT professionals at hospitals to ask for recommendations or to check whether, if you want to implement the system, does our hospital system can cover it or not, so that sort of thing. And also we have to a bit more look forward in the future to sustain this technology adoptions. It will require a bit more of resources, risk management, possibly operational cost increase, and some capital investment have to be done in order to adopt these technologies. That's it. That's the end of my presentation. Thank you for your attention. I will start the session.
Thank you very much for very interesting presentations, Nisa. Ladies and gentlemen, we will have a M.Si presentations. So we have learned about the significant journey of the ECRI to become one of the leading
Okay, thank you so much, Dr. Aida, for nice presentation. Oh, I'm sorry, nice introduction. I'm so nervous. Thank you so much. Okay. Okay, good afternoon, everyone. Also, Prof. Tan and M.Si, and all other guests in the Zoom. I'm so happy to be here. So, in this session, I would like to present about the healthcare-based patient engagement research. So, I think this is one of the important issue in the patient engagement because actually many activities or program could be done at the hospital level and could be done by the hospital or the healthcare itself, but unfortunately not many understand about how to create the program or how to establish the system. So hopefully with this outline we could cover all the issues. So we will talk about patient engagement definition and the framework that are borrowed from National Health System from UK, and then patient engagement and research, and then some example. I will provide 3 examples for the hospital. Okay, if you look at the definition, I think Ms. has already mentioned about that definition. So we start with the definition of the patient first. Who are the patient? Patient are someone receiving care and the one who providing real-time feedback, or could be also the one who completed the care, and also the one who experienced harm, and maybe could be also member of the public. Because the concept now is not only for the patient but also the patient and public involvement. So we need to understand the definition first. And then if we talk about the patient engagement for patient safety, it means that how we could engage patient and the public. So when they get the services from the healthcare, they are free from any unavoidable harm. So there's no like increasing knowledge or increasing trend that patient perspective and the active participation is critical in making healthcare safe. So patient should be considered as a partner, so which means that patient and the doctor and the healthcare provider should have an equal position. So within this partnership, it could making the health system safer and also more people-centered, also producing good outcomes, as well as building trust or regaining the trust. Because sometimes when incident happen to the patient and then the patient will lose trust to the healthcare, and gaining the trust again or building the trust again is difficult. So this is one of the important background. And based on the OECD study about the patient safety, patient engagement for patient safety initiative from 21 countries. So you see that low engagement is in patient treatment. It will associated with the higher healthcare costs. And then technology, as mentioned by M.Si, can help stimulate the engagement. And then by engaging patient, it increase patient satisfaction and also better healthcare outcome. So based on the OECD publication, so patient and family and caregiver, even citizen engagement could be done at the local or clinical level, institutional is like a hospital level, and also at the community, for example at the primary care and the home care, and also the national level or healthcare system. Now, this one is related with the development of the national policy. So I think for the last point, I think we should we have to look back at the first keynote speaker presentation, whether the patient engagement already addressed in the development of the national policy. Okay, so what is patient engagement? Patient engagement is encouragement. So we encourage the patient and the carer and the family to work together with the health professional. And also, I think this is also mentioned by, Dr. Nia as well, that when the patient have to be hospitalized, so this puts the patient in the position that, if you look at this article or this quotation, is one of the most disempowering situation, because mostly patient will be the object and they have to just follow the recommendation from the healthcare provider. So most of the patients are not aware that they could refuse, for example, the treatment. They could ask further question about the treatment, and then even they could choose other doctor if that's possible. So patients have the right to do that. So this one of the framework from the National Health Service, which so that the patient engagement could be done at 3 different levels. So this is the individual level, and the second one is organizational level, and the third one is at the national level or the policy making level. So, and the strength of the involvement or engagement is different. So within this one is, the first one is patient, this is just like provide information to the patient. The communication is usually one way. What are the example? The example is the obligation for the health worker to report the incident if they see the incident. We call it duty of candor. This is from UK. Mostly of the example is from the UK. And they have to support the victim of the incident, when the incident happened. This is just like a one-way communication. And this also related with being open policy. So this is the obligation, like our work, we call like mentioned by Dr. Aam, about the open disclosure, that health workers need to communicate the incident to the patient and the family. So this is an obligation. We cannot hide the incident. We have to communicate the incident. And also other example, for example, a hospital provide the video to the patient, and then it's about the patient safety briefing, and also maybe some booklet for people with dementia. There are example of the patient engagement that at the lowest level of the engagement, just providing information, or just like the power is mostly on the health worker or on the healthcare or service provider. And at the medium engagement level, this is the hospital or the healthcare could involve the patient. How they could involve? They could create a survey. So I think this is mostly done by our healthcare system. So maybe survey about patient experience, or maybe involving patient, victim, and family in the incident reporting. I think we haven't done that yet. So, and then patient self-reporting, say patient and the family could report any incident, and also speak up for patient safety program. So all activities here is already two-way communication between the hospital and the patient. However, the power are still in the system, in the organizational. So it's usually led by the organization. And this has the strongest level of engagement. And this is a challenge for Indonesian healthcare system. Partnership or shared leadership. In here, patient is considered a partner, and patient could help in making decision about, for example, the hospital want to develop some new policy, and they could discuss with the patient, and then they could decide together. So for example, this one, Think Safe, this is one activity that is
multidiscipline. For example, there's a patient safety video, patient lookbook, and then discussion time, and also training for the staff. So it's not like only provide one-way information, but this is more to discussion and then partnership with the patient. And also the second one is the listening to you. Yes, this is a leaflet for patient on how to have effective conversation. And after this one, they develop the care plan together with the patient. This is have the highest or the strongest level of engagement. So the challenge is from the hospital to move from this one information to involvement, or even better here is at the partnership. So this is at the individual level. At the provider level, the example is this is a mental health safety thermometer. So this is like a survey for health workers that working in the mental health area. And the survey are published, so the patient could read what happened, for example, in this hospital, what rating of the healthcare regarding the mental health survey. So this is accessible. And for example, at the involvement at the provider or organizational level, there is a patient reporting action. For example, this one include questionnaire and the patient reporting, and then this is the most important thing. Yeah. So staff implement their action plan based on what the concern of the patient. Most often, a hospital work alone. They never involve the patient within the reporting. And maybe also because the hospital still fear that by involving the patient will cause like a litigation or issue or make things more complicated. But this is the right thing to do. Is we need to involve the patient and the family, yeah, in improving the healthcare system. And this is one good example by one of the hospital in the UK. They have the trust board meeting, so it's like a Dewan Pengawas, which involving the patient. So the patient is part of the Dewan Pengawas, and then the meeting is held in the public space. So it's not in a closed room and hiding from everyone, but it's held in the public space and open to public. So it's so that the hospital has the transparency and accountability to the service that they provided. And this is a really good example. So here, within the partnership at the hospital level. So this is the example of the patient-led training on patient safety. So this is mandatory for year 1 medical student, where the training is like the given, or in one of the session of the training, there's like a 4-session training, and I think 2 or half of the session are given by the patient and the family. So it will give a different perspective to the student as well, how they should work together with the patient or carers who experience harm. So this is not only increasing knowledge, but will improve the empathy as well, and also the accountability. And the last one is the safety of the system. This includes the creating of the policy, especially at the national level. So you could see this is from the US. From the US, the lead from hospital safety grade is provide information at the national level to the patient and the family and the public about this level of safety in their hospital. So for example, if I want to go to hospital, I want, for example, if someone, not me, but someone going to have a labor and they want to visit the maternity unit, they could check from the website which hospital that has the lowest incident or the lowest infection related to the maternity unit, for example, like that, or which one that have the safest delivery option. So that is possible here from the US. And the involvement level, this is a two-way communication. So this is choosing wisely, this is a campaign for the healthcare provider and the patient to engage in conversation, to talk about which treatment or which medication that is necessary or that is unnecessary. So I think what happened now is like the patient just follow what the doctor instructions and taking this medication or doing this test. So within choosing wisely program, so they engage in conversation. And also this one is really good. So this is, I don't think we have this one yet in Indonesia. This is the creating an advisory group, including patient safety stakeholder and patient as a member that provide guidance to the Ministry of Health. So for example, in developing the policy related to health, so they could include the opinion or the perspective from the patient group. And this one is the partnership, the highest level is, I look at the one report from the UK where we invite someone who experienced harm to lead the investigation of the incident. So there were deaths of some babies and mother in one the hospital in the UK, and the national investigation was led by one of the parents. So that is possible to do, yeah, because not all the patient or the patient family have a poor literacy. Sometimes they are well educated and they know how to do the audit, and we could invite them to lead the investigation. I think this could be happen also in a hospital unit. Okay, let's move to the patient engagement in research. So, okay, I'm sorry, it's a bit small. So, patient engagement in research, especially based on the healthcare, is give a big opportunity for the hospital to improving care. So, we look at some example here. Okay, this is interesting statistic here. So we have so many families visiting hospital every day. In here, like 80%. Or, however, it's only very few of them are invited to join a research. So maybe if you work in the hospital, you could look back at the hospital data. So how many family or how many patients that's already involved in the research? I think it's only very few. While the benefit of involving patient is huge. Yeah? So they are more relevant to the participants and then acceptable, understandable, and provide better experience. Why? Because if we involve the patient or the family in the research, yeah, they will talk using or they will speak using the patient language. And if we invite other patients to give or complete the survey, it will be really understandable, more understandable for them. Compared to if the researcher just develop the instrument based on his or her perspective, yeah, without inviting the patient. That's an example. So this is from a systematic review which try to find what are the best method to identify patient. So actually that's the main question. Unfortunately, based on the study finding, the study could not find the best method because mostly a descriptive study. And how they could invite patient in the research. So first one is convenience sampling. So convenience sampling is very easy. You just come to the outpatient unit and inviting people to complete the survey or do the interview. And also the second one, patient also volunteer. So you just like make a poster and invite the patient who want to be participate in the study and provide a contact number, and the patient will contact the hospital. That is the second one. And also invite patient as the representative. For example, if the hospital have a huge number of the patient with diabetes, so they could invite one of two, or invite some of them to the focus group discussion in the hospital, is asking about what service related to diabetes that they prefer to have. Or it could be like a randomly selected from patient, for example, who coming to the outpatient cancer therapy or something like that. So this is all the example. And the second one, what are the best methods? Once again, they could not find the best method, but they could identify some of the methods that used. For example, focus group, interview, survey, attending regular meetings. So this is a long time, like need a longer time than compared to the first three. And then the most active one is serving on a study board or advisory council within hospital. So, for example, if usually in a hospital there's a the hospital safety quality committee, but you don't have like the patient advisory board or something like that that reflect the voice of the patient within hospital, and that is important. And this is the finding. So the highest one is mostly on the focus group and the interview and the survey, and the lowest one is on the organizational participation. Is always the lowest one. So again, this is the challenge for the hospital. So the observed benefit is we can find this in many literature, how involving patient in the research, it could lead to higher enrollment and retention rate and provide better outcome for the research itself. Okay, how about the harms and the barrier? The harm and the barrier of involving patient in the study within hospital is like a frustration with training, because the patient have to be at home to attend training first, and the transportation and the attendance. And then extra time, because sometimes the patient will drop out in the middle of the study or the research. And also time constraint, and maybe it will incur additional funding for patient engagement. Also, the concern about the symbolic effort. There's like, oh yeah, our hospital involves the patient in the decision making, but that's only a symbolic. Yeah, it's not the real one. Yeah, this is another harms. And then potential challenge, maybe patient may introduce irrelevant concern, making research invisible. But however, all of it could be solved with the clear expectation from the researcher to the patient and the family since the beginning of the study, and all have to be written and then understand and discuss before we start the study. Okay, so these are the examples. I start with the simple one and then move to the complex one, because if I show the complex one and then maybe all the audience will think that, oh, this is too hard, this is too difficult, it's hard to do this, okay? So this is our example of the patient engagement in the inpatient setting. So I'm sorry for a small size font. I could share the PowerPoint later. So there's so many engagement methods. For example, here this is the application base. So this is the use of the application for pediatric hemodialysis unit with the aim to not remove actually, but like to distract the patient from the pain with the chronic physical pain. So to remove that one. This is the function mostly for entertainment, but it's still cute. And this one using a game, novel game, to improve hospital patient confidence in managing their own care. And then mobile phone access for within the emergency department for interactive reporting, and some others like the one that is already described by Dr. M.Si. Okay, this is the example in the older patient engagement for the medication safety behavior. So by doing this research, so they asked the older patient in the 6th ward. This is a study from Australia. They asked about whether they want to check their medication chart or whether they want to administer their medication chart, because they are elderly. So most of the patients say that they don't want to do that. They disagree to that. So following this one, so the hospital have to develop the strategy, because they have maybe some patient with other different age group who want to administer or want to be independent in administering the medicine, for example, while there are other group that they want to rely on the nurses, for example. So this is important to understand the characteristic of the patient within the hospital. This is another example. So this is the strongest one, and then this is a big challenge for the hospital, especially, or other healthcare in Indonesia, how to could include the patient representative in the hospital. So patient could provide feedback not only on the response time, but maybe also on the experience on a certain kind of disease that maybe only the patient who understand. So if you look at many study in overseas, there are so many movement that was led by someone or the patient who have a certain kind of disease or they experienced harm before, and then when they are invited as the part of the hospital to do the quality improvement, so the result is significant. Okay, so this is one of the example about the complex one. So this study was done in the Ottawa hospital. This is a large hospital with 1,200 beds. This consists of 3 hospitals. So the hospital want to develop the patient and family engagement program that is sustained. So maybe this could relate with Dr. A.M. Question in the first session about how could we make this sustain, because we need to create the system first. Not only about open disclosure, but also related to the other patient engagement program. So the first one is, this is the structure within the hospital. And we could compare this with the Indonesian one after this, okay? So within this hospital, they have the program first, and then they have the method center within one of the research institute that is part of the hospital. So in Indonesia, maybe each hospital already have the research and development, maybe, or we call it like education and training unit, or research and development. Bahasa Indonesianya leadbanknya rumah sakit ya. So this is like the leadbanknya rumah sakit, and then they have the expert here and the methodological research. So they back up on the methodology of the research. And then they also have the Office of Patient Engagement. This is, I don't think any hospital in Indonesia have this one. So we need to develop a unit, that is become the representative of the all patient within hospital. So this is still inside the research institute. And they need to have this same perception and same vision. They need to align all the institutional priorities. Then they develop the supporting policy. So like what Dr. Aan mentioned, we could not start the open disclosure if we don't develop the policy first. So we need to develop the policy. And then provide the ongoing education and support, and also make like the innovative recruitment and evaluation procedure or something like that. So this is an example of the vision, and where here patient engagement are listed in the strategy. And then the step A here, I already written here, put it here, so you can look back later. And then this is the structure. So, for example, what happens if the hospital thinks that we don't have the expert, we don't have someone who understand about how doing the good research, then the hospital could collaborate with academia, and that's happened in many places around the world. So, for example, this is the hospital research institute, like the Badan Litbang or training ya, apa namanya itu? Apa itu Pak? Pendidikan dan pelatihan. So many names. And then the school invite also the academia or research institute from academia, because the collaboration between the hospital, academia, and other stakeholders are important. And then here, this is the example from the patient engagement office. So patient engagement office consists of so many different. For example, this is related to the deaf patient, cancer patient, renal patient, and this is more than 200 patient or caregiver or family advisor are listed here. So the collaboration should be between the hospital, the research institute, and also the Office for Patient Engagement is in the middle. So by doing this, and then we have the system they established within the hospital to do the engagement program. But if we don't establish the infrastructure first, I think that will harm and not sustain. So I think this is one of the important key messages from this slides. And then the conclusion is it's never be too late, for healthcare to initiating a patient engagement program or research. And then necessary infrastructure is a must. We cannot say that we don't have the funding. So if you don't have the funding, and then how could, because for example, if we invite the patient, we need to provide like a meal for them, or sometimes we provide some small token for the transportation. I think that will support them as well. And also, even though for delivering training, there is some cost for paying for the trainer or something like that. So it needs to have like aligned priorities. So it must be done by the hospital leadership, hospital manager, and all our health workers have to understand the importance of building the necessary infrastructure. So foster collaboration with external stakeholders, including academia, and also maybe professional organization, because in here this looks like professional organization is like working separately from the hospital and the academia, even though we have the same issue on the important, for example, like the patient engagement for patient safety. And then the last one is about emphasize patient-centric approach by empowering patient to take the lead. So we need to give the opportunity to the patient and the family to take the lead. And I think the voice of the patient is really important, but I don't think that we have give proper attention to that until now. I think this all for me. Thank you so much. Any question? I'm happy to receive any email. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Ina, for wonderful presentation. Ladies and gentlemen, while we are waiting for the question from the audience. Actually, but also their family to work together with the healthcare professionals to provide the best and the optimum of the healthcare service. We also learned that involving patients' engagement needs to be started from the individual level, the organization level, and also the national level. We also learned that it is very essential to involve patients in some research related to patient safety. Of course, this is to provide the best evidence, because currently they haven't the best methods to involve patients in research. The best method is only applied, depends on the aim and the study design as well. Alright, so if you have any questions, feel free to say directly, to speak on directly. Yeah, we have participants to ask, and we have two. The comedian, please circulate the microphone.
How is there any experience that you had before or any best practice outside regarding the collaboration between the academia and also the hospital? Because in my hospital, we are just, I think we run a long time ago, but we just accredited this beginning of this year. We are also hosting the dental student of Andalas University to conduct their clinical case. So most of the problem is the doctor and the dentist that work in the hospital also work in the university, and the workload is very higher. So I don't think that they have still time for the collaboration, and I think also regarding the funding as well, it's a bit challenging at the time to conduct the high patient engagement, something like that. So maybe can you share us is there any experience or any best practice out there how we create or establish the infrastructure regarding the collaboration between the academia and also the hospital, especially the hospital for the patient engagement?
Thank you for
regarding collaboration with academia. So actually what happened now, the academia is already work with the hospital. But what to say is like the collaboration is not like a formally initiated, and mostly like for example, if the student need a place to do research and then they could do the research at the university, at the hospital, for example. The thing with that one is there are so many actually activities that being done in the hospital. If we could say that a research that was conducted by students, but we need something that align with the hospital priority. So, for example, if the hospital has a priority for on some activity, they could invite academia. Oh yes, we accept the collaboration in research only in this certain aspect because this is aligned or this is our priority the most. So that one of the example. By doing that is, I think that will be more effective and helpful as well for the student, and also give like a big benefit to the hospital. But the thing that I mentioned is formal collaboration is like we need to work on the certain area that become the main issue by working together. For example, like our center is focusing on the education and research, and we have some certain topic that will be our main focus for research. And like we done previously, we invite the hospital. For example, we did the open disclosure survey, I think in the early of this year. And we invite the hospital. For example, if you feel that this issue is important, so you could complete the survey. And for example, if you complete like more than 20 respondents from your hospital, and then we will provide report for you. That we have done on the open disclosure. And once again, we do that on the surgical safety checklist. So we work with the hospital because surgical safety is an important issue. So we offer the hospital, if you want to join us in this study, so this kind of support that we need, because as a research center, we could not like provide funding to the all activity. So the cost of the activity should be shared. For example, okay, we provide the training, we will give the training, but then if because the training is delivered at the hospital, and then the hospital need to arrange the participants and then maybe provide some snacks, something like that. So that should be shared by both parties, because I think some hospitals just think that if they join the research with academia, all the funding or all the costs will be covered by us. So it's not like that. There has to be a mutualism relationship between two parties. And usually that, for example, if we provide training for them, so it could be attended by all the health workers, and then we could give the certificate. But once again, there should be you know what is that we discuss at the front. For example, if we have the MOA, that will be good, but we could start that as a contractual basis as well. So that is important for me. And also, I think it's very important for the hospital to set the priorities, which area that you need to focus next year. And then if the student coming and they just don't know what data that you have, what problem that you have, you can direct them to the priority area. I think that's the technical or the simple thing that a hospital could start and getting more benefit from the research I think that's all for me.
Alright, thank you, Dr. Nia, and thank you for Sika. If you still have some questions, we can discuss during the lunch break. Right, I saw that Prof. Yeah.
Closely with the academic system to come together so that we can improve care. For example, in SingHealth, we work together with the Duke NUS and Duke to ensure that we have a good healthcare system. We improve a healthcare system through research and education. And so it's sort of imprinted in us that you cannot do it all alone. You need education and research, and that's where the university comes along. Because they will have the education methodology, the research methodology to do the appropriate way to care. In fact, patient safety is actually the healthcare business, right? Healthcare industry business. It's actually, in fact, in SingHealth, the healthcare, the hospitals are more interested in patient safety, and we actually engage the university to help us along. Here I can see, in the university, because your university itself actually encourage patient safety, and I think there should be a corresponding, endeavor from the health cluster, basically the health industry to come together, because it takes two hands to clap. So I think there would be synergy if we work together and all realize the importance of that. So my question is that this system in Indonesia, is it that the university is more into the patient safety, or is it the health care organization? So I'm just wondering, is it particular to any cities or in general? What is the status now of this? Thank you.
So the speaker says we have invested.
That is a hard question. Okay, so patient safety is a hospital business, yes. And we have some agency at the national level who encourage patient safety. But we don't think that's enough because the support is not like reaching each hospital. And then whether university or more focusing on patient safety, I think that is hard to answer as well. That we could say that, for example, the education in here for the healthcare professionals already, they say that it's already included patient safety in their curriculum, but we don't know the portion yet. And I'm not sure whether it's already include the basic foundation of patient safety, like for example empathy, communication, and then like open disclosure. So that's from the university side. So yes, we're focusing on the patient safety, but it's not that we can see it like a great emphasis like in overseas, like in Singapore. So maybe in Singapore or in Australia, which I see that university or academic institutions really encourage patient safety, and they have like a specific patient safety training that like a mandatory for the student, and that one. And then that's why we try to help healthcare and the hospital by assisting them in like doing the advocacy on patient safety, but also like helping the patient, like increasing the knowledge of the patient safety. I think hopefully that answers your question.
M.Si would like to add some comments, so please.
Thank you. This works. Just to add on to the answers and also share a bit information from M.Si experience, especially at our APAC office. We engage also with institutions and universities, allowing students to do internship at our office and get them engaged in the work that we do. So all of our work put importance of safety, not just patient safety, but the device safety itself, which also have the effect on the patient safety in the healthcare setting, at least for within the educational ecosystem in Malaysia. At ACRI APAC, we open position for students to attach to our company for 3 months, 6 months, give them that exposure. When they have that exposure, they also actually understand that, oh, it is a thing, safety in patient safety, medication safety, medical device safety is as important as how the industry and academics and healthcare system look at as the utmost important. Yeah.
Thank you so much. So is there one more question from the audience? Okay.
I ask questions.
Okay. So would you mind a little bit? Okay, so please, we have one participant to join from the Zoom to ask questions.
Good afternoon.
Yes.
Hello. Yes. Are you hearing me?
Yes, we hear very clearly from here.
Okay. Yeah. I'm representative. May carry to with this.
Okay, so how do we initiate the patient safety quality that involving a patient and healthcare professionals, if I'm not mistaken?
Yeah.
Okay. Yeah. So I would like now to give the screen design. You would like to respond first?
The question on how to initiate, it doesn't come just from own awareness. It has to come with the readiness of the infrastructure surrounding the position to establish a certain system so that you start engaging, you can improve safety in your care. As I mentioned earlier about having good supportive infrastructure, the system that I was mentioning about, it requires implementation from higher level of the management. It requires some investment to establish it. But that would depend on the policy making. So when you have a policy in place nicely, then you are able to start from the top to down approach in this sense should be more effective to initiate this, and that requires many support. Also, I think I remember mentioning during my presentation just now, of course my topic was on technology, but this also involved human touch in terms of engaging. When you increase or improve engagement, you can give safer care for the patient, which is can be more valuable and with more outcome for the patient. The patients are the ones benefiting from it. So you can also have that instill in internal instinct to start with yourself. If you are a healthcare provider or if you are a patient, I think I am very supportive of the idea of having a patient advisory board or representative of patients at a hospital. And that can also be a point to initiate this engaging system. I believe that can also be one of the key drivers to support engagement. In a way, subsequently to improve safety.
Dr. Ina, maybe you want to respond as well?
Okay. Okay, for answer for Bapak yang dari Zoom tadi, organisasinya apa ya Pak? Dari ada diabetesnya gitu ya tadi ya?
Persadianya.
Kepanjangannya?
Persatuan Diabetes Indonesia. Itu ya asosiasi resmi untuk diabetesi di Indonesia.
Oke. So
sebelumnya dipegang Dr. Sony Surabaya.
Oke, baik. Terima kasih atas pertanyaannya. So thank you for the question because I try to give an example based on the setting of your organization, because your organization is like the association for the patient with diabetic. So example of the patient engagement that program that would be done is first is educate the patient about their rights when they visiting healthcare. I think that's most of the fundamental things because many patients are not aware what are their rights. And also educate them on how to communicate effectively with the health workers. Because we could see that the patient are the expert for their self, for their disease. So I think how to communicate effectively what are their wants, what are their beliefs, and then what are their preferences is very important. And many patients don't know that they could, for example, disagree with the doctor decision or with doctor treatment or something like that. And I think that's the second one. And then also the next one could be about the transition from the healthcare to home environment. I think that's important as well. So the engagement or the empowerment of the patient, it could be like built on like a providing skill on how to treat their wound at home, how to reach the health services in the emergency situation or something like that. I think that's on the small scope within the organization that could be done by the patient association for diabetic or something like that. And the higher scope may be all the association. This is what we learned from the Singapore, because we visited Singapore like a month ago and with the Prof time, and also there was a presentation from the Singapore Patient Advocacy Network. Am I right, Prof? Yeah. So that also happened in other countries as well, where so many patient associations are united in one entity at the national level. And what are the benefits of having one voice at the national level? We could proposing the health office, the Ministry of Health, for example, when they want to develop or create the health policy. So we need to make sure that the patient voice are included in any decision making. So this is important. But in Indonesia, I don't think we have like a one association yet that cover all the voice of the association. We have so many different associations, but we don't have like a one network to communicate or to raise the voice. I think this is one of the important issue that we need to address as well. I think that's simple for me. Thank you.
Okay, thank you so much to all the speakers, and ladies and gentlemen, apologize because we are quite a way behind from the schedules. So I'd just like to conclude in one sentence about our sessions this afternoon. So engaging patients to be involved in the healthcare service is very essential. It's not only the patient but also their family, and to encourage them to work together with the healthcare professionals and the academia who collaborate in the research is also very crucial to provide the best patients quality and safety. And thank you so much to all the speakers who have joined with us and delivered such a very nice presentation. And also thank you to all the audience. I'll turn over to you.
Thank you, Ibu Erda. Mempersingkat waktu, to symbolize our gratitude, we would like to present each speaker with a token of appreciation in the form of a certificate. Sertifikat akan diserahkan oleh Dr. Muhammad Ardian Cahya, SPOK M.Si, as the coordinator of Research Group Safety and Quality Improvement in Center of Excellence Patient Safety and Quality. Penyerahan plakat untuk Ibu Zaid Hasnida Zindi. Thank you. Mohon tepuk tangannya. Foto, klik. Selanjutnya penyerahan plakat untuk Ibu Ina dan Yanti. Bisa minta tepuk tangannya juga. Kemudian penyerahan sertifikat untuk moderator. Tepuk tangan dulu. Oke, terima kasih Dr. Adrian, Ibu Elisa.
The end of the first International Symposium on Patient Safety and Quality. Thank you for your valuable time to join us. We hope that this seminar gives you insight and knowledge that you can all apply. Sekian dari saya, kurang lebihnya mohon maaf apabila ada kesalahan kata dan perbuatan. Mungkin bisa langsung ke restoran lunch. Oh iya, Zoom juga. Terima kasih atas kehadiran partisipan yang sudah hadir secara online. Kurang lebihnya mohon maaf. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Integrity, rigor, independence. At ECRI, these are not just words. Integrity, rigor, independence. At ECRI, these are not just words. They're guiding principles we've followed for more than half a century as we've worked to protect patients and advance evidence-based healthcare worldwide. Transformational changes in healthcare are giving rise to new and urgent challenges around safety and quality of care. Critical decisions about treatments, coverage, cost, and health policies must be guided by a source of knowledge that is trustworthy, unbiased, and based on the best available evidence. For tens of thousands of healthcare leaders around the world, ECRI is that source. ECRI's undisputed credibility stems from its relentless commitment to independence and integrity, and the strictest conflict of interest rules in the healthcare industry. Today, we recommit to those principles and to our role as the most trusted voice in healthcare. Join us as we shape healthcare, empower and assure healthcare leaders, and protect patients worldwide. Integrity, rigor, independence. It's why we're the most trusted voice in healthcare. Integrity, rigor, independence. At ECRI, these are not just words. They're guiding principles we've followed for more than half a century as we've worked to protect patients and advance evidence-based healthcare worldwide. Transformational changes in healthcare are giving rise to new and urgent challenges around safety and quality of care. Critical decisions about treatments, coverage, cost, and health policies must be guided by a source of knowledge that is trustworthy, unbiased, and based on the best available evidence.